Very good afternoon, everybody. Very warm welcome in Kanpur, and Kanpur Orthopaedic Associations welcomes you all. So we are going to start this function, welcome ceremony. So first of all, before any function, before any ceremony, we always remember our God and Goddess. We do the prayer for the Goddess, Ma Saraswati. So I would request Vandana is going to be done by our Dr. Rajendra sir. Dr. Nath sir, please.
Thank you, sir. Shuklam Brahma Vichar Sar Padmam Adyam Jagat Vyapini Veena Pustak Dharini Abhayadam Jadyandhakara Paham Haste Swatik Malikam Vidhatim Padmasane Sansthitam Vande Tam Parameshwari Vande Tam Parameshwari Bhagavati Buddhi Pradam Shardam Purusha Pratipadyante Devatvam Yadanugraha Saraswatim Jatam Nomi Saraswatim Jatam Nomi Vagdishtatri Devatam.
Thank you, sir. It was so soothing. Now I request our Honorable President, Dr. Sanjay Dhawan, sir. Dr. Sanjay, sir, please come on the dais. Now I will request. Thank you, sir. Now I will request our chief guest, Dr. V.P. Singh, sir. Sir, please come on the dais. Now I will request our guest of honor, Dr. Santosh Rajpal, sir. Dr. Santosh, sir, please come on the dais. I'll request our Honorable Secretary UPOA, sir, please come on the dais. I request our organizing chairman, Dr. Sir, please come on the desk. I request President of Kanpur Orthopaedic Association, Dr. Nadeem Falvi, sir, please come on the desk. I request Secretary of Kanpur Orthopaedic Association, Dr. Vikas, please come on the desk. Now I request organizing secretary, the person behind all this post, Dr. TPS Lamba, sir. I request Dr. Sanjay Rastogi, sir. So please give a bouquet to our Honorable President, Dr. Sanjay Dhawan, sir. And give honor with us by giving us all. I request Dr. Rajan Nath, sir. So please give a bouquet to our chief guest, Dr. V.B. Singh, sir.
ऊपर आ जाइए। सर यही नहीं एक आप क्या जाइए अब सर इधर पीछे नहीं आ
Thank you, Nath, sir. I request our Vice President, Dr. V.S. Sharma, sir. So please give bouquet to our guest of honor, Dr. Santosh Rajpal. Thank you, sir. I request Dr. Nirmal Saxena, sir. So please give bouquet to our Honorable Secretary, UPOA, Dr. Ankur.
रवि सर आगे आइए यस सर
Thank you, sir. I request Dr. Rohit Nath, sir. So please give a bouquet to our organizing chairman, Dr. Gyanen, sir. Thank you, sir. I request Dr. Arup Mukherjee, sir. So please give bouquet to our honorable president, Dr. Nadeem Farki, sir.
Yes, sir. Thank you.
And I request Dr. S.P. Singh, sir. So please give bouquet to our secretary, Kanpur Orthopaedic Association, Dr. Ravi Garg. And request Dr. Harpreet Singh. Dr. Harpreet Singh, please give bouquet to our organizing secretary, Dr. T.K. Lamba, sir. Thank you, Harpreet. So I'll request to all the dignitaries on the dais, please come forward for the lighting of the lamp. Thank you, sir. Thank you. Now I request our organizing chairman, Dr. Jain sir, so please come for the welcome address.
Good afternoon, gentlemen. On behalf of Kanpur Orthopaedic Association, as chairman of the organizing committee of 7th UPOA trauma course, I welcome you all here in this August gathering. And first of all, I welcome the president of Uttar Pradesh Orthopaedic Association, Dr. Sanjay sir, who is a renowned orthopedic surgeon from Agra. I welcome one of our most esteemed students of GSVM Medical College, Dr. Vedpraj Singh, at present the Director General Medical Health Services, Uttar Pradesh. And it is my proud privilege that he has been not only the student of GSVM Medical College as an MBBS student, but also as a postgraduate student in orthopedics itself. So, as a teacher, it is my privilege to welcome him here as a chief guest of this function of the 7th UPOA trauma course. I welcome Secretary UPOA, Dr. Anup sir. Then I welcome Dr. Santosh Rajpal sir, our guest of honor, the senior most orthopedic surgeon present in Kanpur town at the moment. We are blessed to have such a senior man who is always a guiding force for us in every aspect of our endeavors. In every aspect of our organizing endeavors, he has been a force behind all this. I welcome all the faculty who are physically present here. Especially, I welcome Dr. Rajiv Vora, who has come all the way from Amritsar. Then Dr. K.D. Tripathi, Dr. Ashok Vij, and Dr. Sanjay Srivastav from Lucknow. I welcome all the delegates who has come here to attend this function, and I also welcome all those faculty members who are attending the function online as a faculty. With all these words, I welcome you all once again. Thank you.
Thank you, sir. Thank you so much for the welcome address. Now I will request to our Secretary of the Pradesh Orthopaedic Associations, Dr. Anup sir.
Thank you, Ajeet. Good afternoon, everybody. Chief guest of the day, Dr. V.V. Singh, DG Medical and Health Services, a thorough gentleman as I know him. Guest of honor, Dr. Santosh Rajpal sir. Organizing chairman, Dr. G.K. Sengar sir. Organizing secretary, Dr. P.T.S. Lamba. President, Kanpur Orthopaedic Association, Dr. Nadeem Farooqi. Secretary, Kanpur Orthopaedics Association, Dr. Ravi Garg. Delegates, the faculty members, and the members of Kanpur Orthopaedic Association, friends from media and pharma companies. It's indeed an honor to be here in Kanpur for this inaugural function of UPOA trauma course. This is the 7th UPOA trauma course, and today happens to be the World Trauma Day. Today's course is dedicated to two of stalwarts of UPOA, Professor R.K. Shukla sir and Dr. P.M. Gadre sir. I remember my first encounter with Professor Gadre sir when I was delivering a talk in Lucknow, and he was also a faculty there as a guest speaker. Once I finished my talk, I went to him and asked sir for his critical feedback. So first he congratulated me and then gave me few of the suggestions. And I think what I am today is because of the blessings of PM Gadre sir. And he was one of the most humble and knowledgeable person I knew. As far as Professor R.K. Shukla sir, I was unfortunate that I never had an opportunity to meet him personally. But I know many of his students in Lucknow and his proud son, Dr. Saurabh Shukla, also, who is here. And they all talk about Professor Shukla sir very high. And they always say that he was one of the most wonderful teacher and a person. So I bow my head to both these stalwarts of UPOA, Professor R.K. Shukla sir and Dr. P.M. Gadre sir. As I said, that today is the World Trauma Day. And it is disheartening to know that India ranks second in number of road traffic accidents in the world. And we as an UP Orthopedic Association took a lot of steps to overcome these deaths. Few of these important steps are like that if you train the people for basic life-saving training, then you can save n number of deaths which are happening because people neglect when they are dying post-accident on the road. We all have seen such sight very often on the road traffic. Then the other important aspect is that how to fast and early transport these patients to medical facility and prompt management of these trauma patients. And the last but very, very important, that how as an orthopedic surgeon, we upgrade our own skill with the modern way of managing these trauma patients. Because every day technology is changing. So as I said, that as per our commitment to these patients, last month during the Bone and Joint Day week, Indian Orthopaedic Association conducted the online basic life-saving training to students. And I'm proud to say that through Indian Orthopaedics Association, we could train more than 15 lakh students and people all across the India. And UP itself trained more than 27,000 people. In continuation to this academic part, we did conducted almost 30 odd webinars during this 1 year, which were online. And recently, we also conducted a UPOA orthoplasty course and UPOA special course, which was on arthroscopy. Apart from these courses, UP Orthopedic Association gives 15 fellowships every year. And even Indian Orthopedic Association gives 70 fellowships every year. And out of that, 40 fellowships are open for young surgeons. They are wonderful fellowships. So I invite all the young surgeons to please come forward and apply for these fellowships for UPOA and IUA also. I must thank Kanpur Orthopaedic Association, especially Dr. Nadeem Farooqi, who is the president, Dr. Ravi Garg, secretary, and special mention to Dr. Ajeet Tiwari for conducting these online webinars from Kanpur Orthopaedic Association. We would be conducting postgraduate instruction course lecture in Moradabad. The date for them are 4th and 5th December. This is going to be second physical conference of this year. So I'll request all of you to please communicate this message to PG students so that more and more number of people can be benefited by this. And then comes our annual conference at Varanasi. That would be on 25th, 26th, 7th of February. I invite you all to come in large number. This is going to be a wonderful conference under the leadership of Dr. Amit Rastogi and Dr. Kaushal Agrawal. So at last, I again congratulate Kanpur Orthopaedic Association for organizing this excellent UPOA trauma course here in Lucknow, and that too physically. Kanpur Orthopaedic Association, I'm so sorry. So thank you, Kanpur Orthopaedic Association. Thank you everybody for coming over here in large numbers. Jai Hind, Jai IUA, Jai UPOA. Thank you.
Thank you, sir. Thank you so much. Now I request our President UPOA, Dr. Sanjay sir. So please come forward and have 2 words.
Thank you, Ajeet. Very good afternoon, respected dignitaries on the dais and off the dais, respected teachers, seniors, and dear friends. First of all, I would like to pay homage to our departed soul, who was erstwhile president of UPOA from Kanpur, Professor R.K. Shukla sir from 1992 to 1993, and Dr. P.M. Gadre sir from 1999 to 2000. Their contribution to the orthopedics fraternity in IOA, UPOA, and Kanpur has been remarkable. They were actually father figure members. Our honest tribute and respect to them. It's an honor for me to chair a symposium held in their memory. Once again, I am at home and welcome you all to this another academic feast of UPOA, the UPOA trauma course being organized by Kanpur Orthopaedic Association, which is always ahead in keeping the members updated with current concepts and advances in the field of orthopedics. Being my favorite subject, I am in fact always tempted to see the advancement in the field of trauma. And with Sengar sir and Lamba sir teaming up for the purpose, it means you are fortunate enough to have something extra in this subject with the galaxy of specialized faculty and with their wisdom. I'm sure that every one of us are going to get some wiser at the end of the symposium, and we have some practical tips which will be very useful in our day-to-day practice. So looking at the latest scenario of the dilated COVID-19, we are now hopeful for having much more upcoming such physical events. Of course, with the mandatory safety measures we have to make for that. And this is really something we all were eagerly looking for. I once again wish the team KOA all the very best and success to this UPOA trauma course. And thank you all for spending time for your own event, this UPOA trauma course. Long live IOA, long live UPOA. Jai Hind. Thank you.
Thank you, sir. It's a huge honor and privilege for us that today we have the chief guest, Dr. VP Singh sir, in between us. So I request Dr. VP Singh sir. We are not unaware about sir. He's very well known and very famous in Kanpur. So I request you, sir, please come.
इस 7वें यूपीओ ट्रॉमा कोर्स के ऑर्गेनाइजिंग चेयरमैन हमारे टीचर डॉक्टर जी के सेंगर सर, इस कोर्स के ऑर्गेनाइजिंग सेक्रेटरी हमारे सहपाठी डॉक्टर लांबा, आज के गेस्ट ऑफ ऑनर डॉक्टर राजपाल सर, यूपीओ के प्रेसिडेंट डॉक्टर धवन, सेक्रेटरी डॉक्टर अनूप अग्रवाल, केओए के प्रेसिडेंट डॉक्टर नदीम फारूकी, सेक्रेटरी डॉक्टर रवि गर्ग, सामने बैठे हमारे टीचर डॉक्टर संजय रस्तोगी, डॉक्टर आरनाथ, हमारे सीनियर्स और साथीगण। कुछ दिन पूर्व जब डॉक्टर जी के सेंगर सर का मेरे पास फोन आया और मुझे चीफ गेस्ट बनने के लिए आमंत्रित किया, तो मैंने तुरंत एक्सेप्ट कर लिया। इसी बहाने में अपने ऑर्थोपेडिक साथियों के साथ मिलने का मौका मिलेगा, क्योंकि इधर 3-4 वर्षों से जब से प्रशासनिक पद पे आया हूँ, किसी कार्यक्रम में भाग नहीं ले पा रहा था। आज का कार्यक्रम नॉर्थ इंडिया के दो महान ऑर्थोपेडिक्स व्यक्तित्व के मेमोरी में आयोजित हो रहा है। डॉक्टर प्रोफेसर आर.के. शुक्ला, जिनके अधीन मुझे कार्य करने का अवसर मिला, हमारे टीचर थे, बहुत ही सरल स्वभाव के थे, सदैव सबकी मदद करने के लिए तत्पर रहते थे। डॉक्टर पी.एम. गद्रे, मैं समझता हूँ नॉर्थ इंडिया में ऑपरेटिव ऑर्थोपेडिक्स को नई ऊंचाई ले जाने में इनका बहुत बड़ा योगदान था। इन दोनों महान व्यक्तित्व को मेरा सादर नमन। जैसा मुझे बताया गया है कि आज का जो ये सिंपोजियम है, रिसेंट एडवांसेस इन ऑर्थोपेडिक्स ट्रॉमा, मैं समझता हूं कि जो हमारे एमिनेंट स्पीकर्स हैं, उनके जो लेक्चर्स होंगे, डिस्कशन होगा, उससे हमारे जो ऑर्थोपेडिक सर्जन लोग हैं, नई विधियों की जानकारी मिलेगी, रिसेंट एडवांसेस के बारे में उनको मालूम होगा। यूपी हेल्थ डिपार्टमेंट ट्रॉमा में क्या कर रहा है, इसके बारे में ब्रीफ में थोड़ा सा आपसे डिस्कस करूंगा। एक प्रोग्राम है, नेशनल प्रोग्राम ऑफ प्रिवेंशन एंड मैनेजमेंट ऑफ ट्रॉमा एंड बर्न इंजरीज। इसमें ट्रॉमा सर्विसेज को 4 लेवल में डिवाइड किया गया है। सबसे बेसिक लेवल 4 की है एम्बुलेंसेस हमारी। एट प्रेजेंट पूरे स्टेट में 2200 BLS एम्बुलेंस हैं, जिसको आप लोग 108 कहते हैं। इसमें बेसिक लाइफ सपोर्ट के इक्विपमेंट्स होते हैं, मेडिसिन होती है और एक एमएनसी मेडिकल टेक्नीशियन होता है। और दूसरी हमारे ALS एम्बुलेंस है, एडवांस लाइफ सपोर्ट एम्बुलेंसेस। ये इस समय स्टेट में 250 है। ये सब 108 नंबर जो कॉल नंबर है उससे इंटीग्रेटेड होती है। दूसरा है हमारा लेवल 3 के हॉस्पिटल्स, जिसको हम ट्रॉमा सेंटर बोलते हैं। ये यूजली सब डिस्ट्रिक्ट हॉस्पिटल्स में है या जो नेशनल हाईवे में हमारे पब्लिक हॉस्पिटल हैं। सैंक्शन इस समय 47 है, लेकिन फंक्शनल इस समय सिर्फ 31 है। इनका स्टैंडर्ड ये है कि हर 100 किलोमीटर में एक ट्रॉमा सेंटर होने चाहिए। कॉन्सेप्ट यही है कि गोल्डन आवर में कोई भी क्रैश का या एक्सीडेंट का पेशेंट हो, तुरंत पहुंच जाए वहां पे। थोड़ा सा इसमें जो हमारे 31 फंक्शनल है, टोटली फंक्शनल नहीं, पार्शली फंक्शनल है, क्योंकि हमारे यहाँ स्पेशलिस्ट डॉक्टर्स की बहुत कमी है। जैसा कि आप लोग जानते हैं, अब नए स्पेशलिस्ट डॉक्टर्स हैं, वो हमारे गवर्नमेंट सर्विस में नहीं आना चाहते हैं, लेकिन इसके लिए भी हम लोगों ने एक चेंजेस किए हैं अपने सर्विस रूल में। अब जो नया स्पेशलिस्ट डॉक्टर आएगा उसको सीधे हम लोग लेवल 2 में पोस्टिंग देंगे, वो भी काउंसलिंग के हिसाब से। उनसे पूछा जाएगा कि आपका किस डिस्ट्रिक्ट में लेना चाहते हैं, किस प्लेस में लेना चाहते हैं, और उनको होम डिस्ट्रिक्ट में भी अपॉइंट करने की अपॉर्चुनिटी दी जा रही है, इसलिए कि हमारे पास ज्यादा स्पेशलिस्ट आए। लेवल 2 के ट्रॉमा सेंटर मेडिकल कॉलेज में है, और लेवल 1 के जो स्टेट ऑफ आर्ट ट्रॉमा सेंटर है कुछ राज्यों में है। सबसे नियरेस्ट हमारा जयप्रकाश नारायण ट्रॉमा सेंटर है। एक और नई चीज हमारा मिनिस्ट्री ऑफ रोड एंड जो ट्रांसपोर्ट है उसने डेवलप करी है, एक ऐप डेवलप करी, IRAD, इंटीग्रेटेड रोड एक्सीडेंट डाटाबेस। अभी पायलट प्रोजेक्ट के हिसाब से सिर्फ 16 डिस्ट्रिक्ट में यूपी में लॉन्च किया गया है। इसके स्टेक होल्डर डिपार्टमेंट्स हमारे हेल्थ डिपार्टमेंट है, पुलिस डिपार्टमेंट है, रोड जो ये PWD डिपार्टमेंट है, ये है। ये ऐप ऐसे डेवलप किया गया है कि कोई क्रैश साइट होगी तो रियल टाइम जो भी डेटा है उसकी फोटो कैप्चर करेंगे। जब ये फुल्ली ऐप डेवलप हो जाएगा तो एट दैट टाइम हर जगह मैसेज चला जाएगा, चाहे वो नियरेस्ट हॉस्पिटल है, नियरेस्ट एम्बुलेंस है, पुलिस डिपार्टमेंट को, तो सब अलर्ट हो जाएंगे। हॉस्पिटल अलर्ट हो जाएगा नियरेस्ट कि भाई ये क्रैश हुआ है, पेशेंट आ जाएंगे यहाँ पे, तो बी प्रिपेयर फॉर स्टेबलाइजिंग दैट पेशेंट। आपने हमें बुलाया यहाँ पे, डॉक्टर सेंगर सर, डॉक्टर लांबा और आप सभी का हृदय से आभार, मुझे ये सम्मान दिया। धन्यवाद।
Thank you, sir. So before we end the procedure, before we end the ceremony, we will pay our tribute to our two giant persons on whom shoulders we are riding the whole Kanpur Orthopaedic Associations, and we are blessed that we have the two legendary persons in between us. So we'll pay our tribute to them, Dr. P.M. Gadre sir and Dr. R.K. Shukla sir. So I'll request Dr. Saurabh Shukla sir. So please come forward, Saurabh sir. And I'll request Dr. Jain sir. So please come on the dais and pay your tribute to R.K. Shukla sir. So please stay. Rajan sir.
This is a humble tribute to my teacher and mentor, Professor R.K. Shukla, who was in the Department of Orthopaedics when I joined in 1990 after being transferred from Meerut Medical College. And we owe a lot to him. This is Dr. Ram Kumar Shukla, as he was properly known with the name of Professor R.K. Shukla. Professor R.K. Shukla, as he was commonly known, he was born on 4th October 1937 and started his medical career in GSV Medical College. He did his MBBS in 1965 and MS in Orthopaedics in 1969 under the guidance of legendary Professor A.K. Gupta. Then he joined as EMO in LLR Hospital, Kanpur for some time before joining the faculty of GSV Medical College, Kanpur as a lecturer on 7th June 1973. He rose to the post of Professor Orthopaedics due to his sharp clinical acumen and knowledge. He took up the challenging field of reconstruction of leprosy and polio patients and became HOD Orthopaedics in 1993. He retired from GSV Medical College in 1997. He was guide to more than 100 postgraduate theses and published many research papers in reputed orthopedic journals. He had been closely associated with activities of UPOA since its inception and later served as its vice president and president. He was given Lifetime Achievement Award of UP Orthopedic Association. He was an excellent teacher and had pleasing personality and amicable behavior with his colleagues and students, and always helped people in trouble. That is why he was so popular amongst all. Quite early in life, he had developed interest in a spiritual field. He established an ashram and built a temple on the bank of Holy River Ganges in Srivastava with his personal savings to promote worship and philanthropic activities. During this hustle and bustle, he acquired diabetes, but he managed to keep it under control. He gradually developed chronic renal failure and its complications and was taken to Sahara Hospital, Lucknow. He remained admitted there for some time in ICU, but could not be saved in spite of all efforts. He took his last breath on 31st May 2021 at Lucknow in presence of his son, Dr. Saurabh Shukla, orthoplastic surgeon, Vivekananda Hospital. He is also survived by two daughters, well placed in their respective fields. We fondly remember him and feel that his soul is still showering blessings on us from heaven. Thank you.
Thank you, sir. So I'll request So Dr. Saurav Shukla sir is in between us and he want to say something for the Kanpur Orthopedic Associations. I request you, sir, please.
Hello friends, it's been a very emotional day for me here. I thank the Kanpur Orthopedic Association for remembering my father, and I got an opportunity to meet many of his colleagues, my teachers, my seniors, and he has been associated with this city ever since his birth. And I have seen him thrive. I have seen him grow. I have seen him being happy with his position, which made him what he is today. I just want to add one more thing in his memory. I often used to wonder when I was in MBBS that what is his actual achievement in life. I realized that his actual achievement in his life was his students. And I have got so many calls during his ill health and when he passed away. People actually have cried, the students, when he spoke to me. Anyways, that's not the time. It's not the time for this. I, in his memory, would like to hand over a small token of gesture. Since Dr. Sanjay has been very closely associated with my father, I would request Dr. Rastogi sir to please come in on the stage. And I would like to hand the check to Kanpur Orthopedic Association along with Dr. Rastogi. Thank you.
Thank you, sir, for your kind gesture. So I request Dr. Nadeem Farki, sir, and I hope today Dr. Gadre sir's daughter, Mrs. Seema Gadre, she might be following this program and she's listening us from the States. So I request we'll pay our tribute to Dr. PM Gadre sir. So I request Dr. Nadeem Farki, sir, so please come on the desk.
Dr. PM Gadre, my guru and guru to many in the audience, was born on the 6th of July 1945 at Karachi. His parents came to India after partition in 1947 and settled in Kanpur. He completed his high school education from the Jain Medical Military School in Himachal Pradesh and intermediate from St. Xavier School, Kanpur. He did his MBBS from GSVM Medical College, Kanpur in 1968. In 1969, he joined the Department of Orthopaedics, GSVM Medical College, Kanpur, as a house surgeon, where he came in close contact with the legendary professor, Dr. A.K. Gupta, who was the head of Department of Orthopaedics at that time. He completed his MS in Orthopaedics in 1972, and in the same year, he left for USA. He trained in USA in various specialties, including hand surgery, ortho-oncology at Sloan Kettering Hospital, New York, and of course, pediatric orthopedics. He successfully completed his American board certificate the first go. Because of his love for his country, he came back to India in 1978 and started his private practice. At that time, practice outside of medical college was very rare. But he went on to create a roaring private practice in orthopedics. He also joined Mariampur Hospital as a consultant. Later, he also joined Regency Hospital when it came into existence as the head of Department of Orthopaedics. His areas of interest were complex trauma, hand surgery, ortho-oncology, but above all, pediatric orthopedics. He was the first one to start trauma surgery using AO principles in UP. His love for pediatrics orthopedics had no bounds. He ran a fully packed pediatric orthopedic clinic every week, even at a time when pediatric orthopedics as a specialty was not that well known, particularly in this part of the country. He has treated innumerable children with CTV, DTH, Perthes, SCFE, and other congenital anomalies. He was by far the leading name in pediatric orthopedics in UP at this time. He was a life member of KOSI and attended most of the KOSI conferences as an enthusiast delegate, ever ready to learn new things. He was a regular at most Indian Orthopaedic Association conferences and the UP conferences, UPOA conferences. He also organized many conferences in Kanpur. He was elected as president of the UP Orthopaedic Association in the year 1999-2000. He was awarded Lifetime Achievement Award at Bareilly and Gold Medal of UP chapter at Aligarh. Today we have subspecialties in orthopedics like hand surgery, spine surgery, joint replacement surgery, etc. But way back 30 years ago, Dr. Gadre tried to create a team of specialists. I am personally indebted to him because what I am today is in a large measure because of him. He made us climb on his shoulders to reach for the sky. Whenever there was a difficult operation or a new operation, and we are reluctant to go ahead, he would always encourage us to do so. He would say, "Main hoon na." You do it if there's a problem, and if there was if the operation did not go as per plan, he would be there to face the flag on our behalf. His collection of books, journals, and instruments was unparalleled. He always encouraged us to buy books and read them as well, and also to buy the best quality instruments. At that time, it was imported instruments. The instruments were very costly, but he would insist that we buy the best because he used to say that if you have good tools, then only you can do a good job. He was young at heart and always willing to go to new places and gain new experiences. He was ever willing to forgive and forget. Even people who used to criticize him, when in trouble, would ask him for help, and Dr. Gadre would never say no. In most conferences, our team went together. He was short in height, but was surrounded by tall bodyguards like Dr. Rajiv Agarwal, Dr. Govindji Shetty, and myself. In many conferences, if perchance he was not with us, people would ask, "Sahab kahan hai?" Most people identified us as the team, and Dr. Gadre would introduce us to all his acquaintances as well. Unfortunately, he was diagnosed with liver cancer in December 2016. He put up a brave fight against that adversity and kept on working till the very end with the same passion and zeal. He was in active practice till the 31st of December 2019. But on the 1st of January 2020, he suddenly fell ill and got admitted to Regency Hospital. He finally lost the battle and passed away on the 6th of January 2020. There's just one thing I would mention, that his wife, who was so-called fit at that time, also passed away just 1 month afterwards. And all of a sudden, and his children, that he has 2 children, 1 son and daughter, both are settled in US and doing well. I'll just add one line from Allama Iqbal. हजारों साल नरगिस अपनी बेनूरी पे रोती है, बड़ी मुश्किल से होता है चमन में दीदावर पैदा. Thank you.
I welcome our President-elect UPOA, Dr. Ashish Kumar. He is in between us. So I'll request Dr. Rajan sir. So please give bouquet to our UPOA President-elect Dr. Ashish Kumar. And I request our organizing secretary, Dr. TPS Lamba sir, so please come and give a vote of thanks.
Thank you all for coming and being a part of 7th UPOA Trauma Course 2021. As you know, human beings are the only species on the planet who has found a way to transfer knowledge down the generations faster than the evolutions. So we are here to take a knowledge from our learned speakers. This is a hybrid event. Some of our faculties are present, others are from the virtually online. We have an exciting talks and amazing cost of learned speaker lined up for you. Before we dive into it, I would like to remember our Professor Ankur sir and Dr. PM Gadre sir, who will be us forever in our memories. They are great orthopedic surgeons, wise mentor, and good teachers, always guiding us. I would like to thank our chief guest, Dr. Vedbra Singh, who is an orthopedic surgeon as well as my batchmate, and he is a Director General of Medical Enhancement State. I thanks Chief Guest of Honor, Senior Most Orthopedic Surgeon, Dr. Santosh Rajpal sir. I again thanks President UPOA, Dr. Sanjay Dhawan, Secretary Dr. Anup Agrawal, and President-elect Dr. Ashish Kumar for honoring us with your presence and taking time off your busy schedule, sir. I thanks our respected faculties, speakers who have taken the great pain to travel and come here to deliver their talk physically. Dr. Sanjay Srivastava from Lucknow, Dr. K.D. Tiwari from Lamba, Dr. Rajiv Vora from Amritsar, and Dr. Ashok Vis from Agra. I am grateful for your talk and I give thanks in advance and really appreciate your kindness to share your wisdom with everyone here. Organizing the conference during COVID time was not an easy task. It would not have been possible without the energy and enthusiasm of our younger colleague. I thank Dr. Naman Kanodia, Dr. Vipinji Singh, Dr. Ravi Garg, Dr. Saurabh Chawla, and last least my blessing by our chairman, Dr. G.K. Sengar sir. Thank you for all for hard work and dedication to organize this event. Finally, I would like to thank all my sponsors who supported us, helped and bring this conference to life. Knowledge is the power supreme, and I hope the whole remaining day will be valuable and add new firepower to your arsenal. Thank you all and happy learning. After the keynote address, you all are invited for the lunch. Keynote address.
Yeah, thank you, sir. I request all of you, please all rise. We are going to have a Distal anthem. Jana Gana Mana Adhinayak Jaya He Bharat Bhagya Vidhata Punjab Sindh Gujarat Maratha Dravida Uttal Banga Vindhya Himachal Yamuna Ganga Uchal Jaladhi Taranga तव शुभ नामे जागे तव शुभ आशीष मांगे काहे तब जय गाथा
जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे थैंक यू
हाँ बोलिए हाँ like within half an hour. Okay. Don't stop the sharing because there will be a keynote speeches, and after that, yeah. बंद किया जा रहा है अरे वो फिर बहुत बैंड बज जाएगी ये चल रहा है ना इसको
I request all the audience, please be seated. All the audience, please be seated.
पावरपॉइंट का कौन सा एडिशन है तुम्हारा? बहुत बार फोल्डर एडिशन में आपका वो नहीं चलता ना, वीडियो स्मार्ट आर्ट नहीं चलता। नहीं होगा ये किसी ऑडियो विजुअल वाले का है लाइव। Just have to see it. You have to see it.
Good morning, everybody. It's always been a pleasure to come to Ankur and interact with you people. And it's same here again after a very, very long time. The topic which has been chosen for this trauma course, the newer development. I think as an orthopedic surgeon, as a clinician, we all are very much interested in the newer technology and newer techniques. I just came across this. This video is not running. I was just going through an advertisement. I saw this. Even the people they are working on a new thing, a small thing like this depth gauge. It's a digital disposable depth gauge which I saw as an advertisement in USA. So this shows that how much we are interested in developing new things, whatever is small it may be. What I call is the circle of clinical practice. That's when we practice as a clinician, we all encounter newer issues, newer problems. We do our thinking, we give time to it, we try to do some research and come up with a solution to this problem. And when you try to implement that problem in your clinical practice, again it creates another problem to it. So that is what is circle of clinical practice we enter into, and we keep on working on that and we keep on discovering the new horizons. The new development can be in the field of, in the form of new techniques, new approaches, newer material to use for implants in our surgical practice, and the use of latest newer technologies to help our clinical practice and our patients. Let's talk about what are the newer trends in which we are moving in orthopedic practice. The ultimate goal of all these research and development is to provide more accurate anatomical reconstructions of our trauma patients. If it is done with the least amount of trauma, that's a bonus. To provide a better stability to our fracture configurations or injuries, to provide faster rehab to our patient and faster recovery, to discover newer materials which can provide stronger support, which are light in weight and which are more tissue friendly, to reduce the load of infection, because infection, I must say, is a big headache for any orthopedic surgeon who is using heavy implant surgery. And ultimately, we want to be cost effective. Although it never happens. If it is a new technology, it is costly, not a cost effective. But that is what is we are striving to, we are trying to develop. As far as technologies are concerned, the trend of the modern development of orthopedics is toward the automation of surgical procedures. We are seeing more and more use of computers, navigations, robots in the field of orthopedics, and same is happening in the field of trauma also. We are using navigation. We all have seen the 2D and 3D reconstructions of the trauma. That does help in our clinical practice to plan our surgeries better, to plan our management in a better way. Now we are coming up with a smart implant technology. We'll talk about that in the coming slides. There are ways and means to assess the bone healing of the patient, and that can be connected to the smartphone of the patients. How healing is progressing. All these is being done in the near field. We are putting micro sensors inside the patient's implant and body to assess the strength of the implant and the strength of the bone healing. 3D modeling and printing we have been seeing for long. It was there for more than 2 decades in the field of pelvic acetabular surgeries, where we do 3D modeling and we create an exact replica of the patient's fractured bone, and then we try to reduce it and recreate it. We have gone a way ahead. Now we have software on which we can create a 3D model. We can reduce these fractures virtually on the software and even design an implant on that software itself. Once you have designed that implant, you can go for 3D printing of the implant, and you have that exact implant in your hand, and you can fix it on the patient for a more anatomical reconstruction. The same technology is being transferred to the other parts of the body, that is the proximal humerus, proximal tibia, where you need more anatomical reconstruction and where the anatomy is quite different in every patient. These are the areas where it is helping us. Navigation we have been using in joint replacement over quite some time now, and that navigation is now being used even in the spine surgery for the accurate placement of our pedicle screws and better reduction and stabilization of them. Robotics, as we have seen, it is done wonders in the field of urological surgeries, gastrosurgeries, and even the joint replacement per se. The same robotic is being transferred to the trauma also, and people are using these robots in the pelvic acetabular surgeries and the spine surgeries for more accurate reduction and better outcome of the patient. The pelvic acetabular fractures can be very well aligned with the help of robot, and our screw placement can be minimally invasive, and that can provide more stable fixation for trauma patients in the pelvic acetabular surgeries. I was talking about smart implants. These are the smart trial implants which are being used in the hip and the knee. We are using it for quite some time now. These implants, they are providing information about the rotation of the hip joint, the movement of the hip joint, neck length, everything to the software attached, and that can provide you an accurate placement of your joint. The same, sorry. think there's something wrong with this. Let's fix it back here. Just leave it. I'll do it. Thank you. I think there's some slides are missing here. There's some more photographs which have not been taken by the. There are trauma implants available now. People are working on that. These implants, they have sensor into it. That sensor senses the stress taken by that implant. And once you implant that implant into the patient's body, primarily on the first go, the whole stress is taken by the implant itself. As healing goes by, the stress on the implant is reducing because that stress is taken by the bone. And ultimately, you are able to judge your implant is stress-free because the total stress is transferred to the bone. So this is how it works. There is this software which is on the patient's smartphone. You can assess it and you can judge how much stress that implant is taking when the patient is doing a day-to-day activity. So that tells you indirectly about the bone healing. Even there are sensors which are placed inside the bone or along the implant that is assessing the amount of calcification which is going on into the fracture area, and that can again give you an idea how much strength has regained and how much calcification is taking place. As far as newer materials are concerned, since the beginning of orthopedics, we were concerned about the ideal implant metal what should be used. And the ideal metal would be which is non-toxic, non-immunogenic, it should be bioinert, it should have the sufficient strength to take the day-to-day stresses of the body of the patient in the fracture area which we have implanted. It should be very high resistance to day-to-day fatigue or the cyclic loading of the implant which is taking place when the patient is moving. It should be contourable, that you should be able to design it the way you want. It should be neutral to the body fluid and there should not occur any corrosion of the implant. We prefer to have it compatible with the imaging like MRI so that you can take a good MRI pictures when the implanted patient. And again, coming to the last, not the least point, that it should be economical, which never happens. We started with bone pegs approximately in 1500. Then we switched over to brass wires, and then came the ivory rod. All this is there in history. Started using steel plates for fixation inside the bone, and these steel plates started corroding, so we switched over to silver. Then steel alloys on inert materials like aluminium 316 came, and that has been used till date. Titanium was introduced, stronger, more resistant to fatigue, and that was largely used in joint surgery. Then came the titanium about 70 years back. We are still using that titanium in today's practice. Then came the ceramic, again, not for the trauma per se. Much of the trauma implants, they are not of ceramic, but largely it is being used in the joint surgery. Then came the last entrant, that is the biodegradable implants, which has its own sets of problems, as I said before. Now we need more. That is more, it's a super alloy which has been developed and it is being used in the practice. It is a molybdenum rhenium compound, and the advantage of this more is it is stronger than the steel. Hence, you can go for a thinner implants, a low profile implants. It is more osteoconductive than the titanium itself. So the porosity can help in increasing osseointegration. It can be used anywhere in the body and will be more stable and osteogenic. It is one implant of material which is biofilm resistance. That is one thing where we want really to enter. We don't want bacteria to colonize and make a biofilm. Here also it helps. And above all, it is a 3D printable material. So you can use it design your implant on the computer, you can print it and use it for personalization. And it is absolutely non-allergic. Already it has been used there in cardiac stents for long, and now it has been translated to the use in pedicle screws in the spine, and even people are working on use of these material in the foot and hand surgery, because there you need a strong, low-profile implant which can be implanted. So it is helping us there. As far as infection prevention is concerned, we just try to understand how infection occurs. There is a attachment of the bacteria to the surface of the implant. Initially, it's a temporary attachment. In that stage where we do debridement and we try to cure the infection in that state. Then it becomes permanently attached as the biofilm is formed. And as biofilm grows and the bacteria grows, more and more maturation of bacteria occurs, and then it becomes a pulmonary infection, which is very difficult to treat. The ultimate objective is to prevent this biofilm formation and to prevent the adhesion of the bacteria. How it is being done in the newer horizons, that you avoid attachment of the bacteria. Either we all have heard about the antibiotic coated implants. So these are antimicrobial surfaces. We are not talking about that. We are talking about the surfaces which will prevent adhesion of the bacteria. So we are talking about the preventive aspects. By coating with a material which repels bacteria, the bacteria will not attach to the surface and the further progression of the infection can be stopped. This can be done by coating with the material or changing the surface properties of the material. It has been seen that the same titanium surface, when it is coated with the nanotubes, the titanium nanotubes, it prevents adhesion of bacteria because of the surface structure, and hence the progression of infection can be reduced. So this is one area people are working. A prefabricated implant can be coated with a titanium nanotubes, and that will decrease the risk of infection. As far as surgical technique and approaches are concerned, I will not be talking much about it because there are a galaxy of presenters. They will be presenting the technique and approaches in their respective field, and we want to learn from that. I just want to share a broad perspective of the newer techniques. That is, the development is towards the least surgical trauma, that we try to do minimum amount of additional trauma when we are providing the surgery. We want to provide a better stability to our construct. We want our patient to progress to a faster rehabilitation and faster and fuller recovery. And ultimately, we are aiming for a good short and long-term outcomes for our fracture patients. If you see the development of the approaches, initially there were regular open surgeries being done. Then we try to reduce the size of incision, that is minimal invasive surgery, or MIS came into picture. And when we try to do that MIS, we try to reduce the incision size further, and we try to did the percutaneous plating. So that become the MIPO, a very common and fancy term, MIPO. That is a minimally invasive percutaneous plate osteosynthesis came into picture. Later on, the percutaneous term was removed because the people realized even if you do an open surgery, it can be a minimally invasive surgery. So the surgery is minimal invasive if you do the least amount of trauma to the surgical site and you do the least amount of disturbances to the environment around the fracture site. So it became the MIPO. That is the minimal invasive plate osteotomy. This is the percutaneous thing was removed. But now we call it as the MIO. Even the P is removed. Plate is not the mandatory for minimal invasive surgery, because if you are using an interlocking nail percutaneously, you are using an external fixator system. Anything you are using, you are doing a minimal invasive surgery, as long as you proceed with the stabilization of the fracture with least disturbance to the tissue biology and leaving the minimum amount of footprint in the area, so that there is the least disturbance and the whole healing can progress and you provide a stable fixation. So now it is called a MIO, that is a minimally invasive osteosynthesis. We'll hear about these things in the proceeding lectures. Whenever we are taking a new technology, a new technique, we must follow the basics. Do not forget that basics are not going to change. The basics of fracture fixation, basics of bone healing are not going to change. Before embarking for any new technique, we must understand the newer technique, technology, and material. It may be very different with what we think. Once we try to understand it fully, and then only we go for the recommended technique. As a beginner of any technique, any technology, avoid innovation. That's very important. Not from the very first surgery, you will start innovating with that. You follow the basics, you follow the principles, and first you understand that technique and technology fully, then only you can be given a key to change the technique or to modify it. That's very, very important. You might understand it as a very simple technique, but if you go into detail of it, the people have already worked on that, people have already burned their hand, and then they have developed this technique. So we try to follow the technique in a full way. What I say that these newer approaches are like going a new voyage, right? Before going to a new voyage, you check the map that you must refresh your knowledge of that area where you are going to enter. I just give a very simple example that we have been doing hip replacement surgery from posterior approach since we don't even remember. Everybody is so well versed with it. But now is the era of a direct anterior approach or DA, what is very, very common. It is not the same surgery. It is not the same area we are entering. So we really have to understand that area well before going for our new venture. Check your weapons before moving. Do you have enough instrumentation and skill to perform? And do you have recommended implants available? That's very, very important because the standard implant may not be amenable for the minimal emergency or new surgery what you do to plan. And if your ship is ready for the voyage, your theatre conditions, your assistants, are they suitable for the new technique? If not, you have to upgrade to that before embarking for a new technique. And it is always advisable to take the tips from the previous explorers. They can guide you better. You can learn from their experience rather than making our own mistakes and learn from them. So that is why we are all here. So thank you very much for your patience and the whole voyage.
Thank you, Dr. Sanjay, for your keynote address on our theme of the today, what's new in orthopedic trauma. You have very nicely explained from incision, plant to the and new approaches and techniques. Thank you so much. Now we proceed for the lunch and we will recollect after 15 minutes because we are delay like this. Thank you so much.
चालू होगा तो दिक्कत हो जाएगी उसको म्यूट लगा ये भी म्यूट लगा
Hello.
We are going to start our first session of shoulder and elbow surgeries. So our chairpersons are Honorable President Dr. Sanjay sir and Secretary Dr. Bhardwaj sir. So please start the session.
Good afternoon. So I'm going to start with the shoulder and elbow session. The first talk is on proximal humerus fractures. I invite Dr. Sanjay Srivastav from Lamba for his talk on proximal humerus fractures. Dr. Chandan Kumar is there. Please.
Good afternoon, friends. I'm back again. As we were discussing in the morning that we'll be talking about the newer approaches or newer technique, whatever in the field of orthopedics available. I've been given an opportunity to talk about the proximal humeral fracture. And one of the topic which is very close to my heart, I'll be talking about the minimal invasive technique for 4-part fracture of the proximal humerus. These are my disclosures, nothing to do with this presentation. All of you have seen that patients with a very bad malunited proximal humeral fractures, they have excellent functional outcome. And we have seen the reverse also. That we do a perfect reduction. Every fragment is at a place where it should be, and still the functional outcome is very poor. Why does it happen? It happens because as an orthopedic surgeon, we are focusing on the bone itself. And in shoulder, the bone part is very, very small. Largely, the function of the shoulder is dependent on the soft tissues around the shoulder and not on the bone. So that is the difference when you talk about the shoulder joint and the other joint. So we have to keep this in mind whenever we are dealing with a proximal humerus fracture. And these are the soft tissue structures around which we all know from our knowledge of anatomy, that the rotator cuff is the most important structure around the shoulder joint as far as the functional outcome of the shoulder is concerned. Another important fact which we must remember when we are dealing with these kind of fractures, a proximal humerus fracture, when we are planning for the fixation, the lateral half of the humeral bone is actually devoid of any bony anchorage. So the lateral part has to be stabilized with the soft tissue, and the medial part around the head has to be stabilized through your bony screws or implants. So that's very, very important to understand, because whenever these fixed angle implants were introduced to us, the locking plates were introduced to us, it was said that the length of the screw doesn't matter. Even if you are using a shorter screw, you are able to provide fixation. But this is not true when you talk about the proximal humerus. Your screw has to reach to the medial part of the humerus. That's very, very important. And sorry, there's something wrong with this. So it's important that our screw anchorage should be within 5 millimeter of the subchondral, so that we have a gap of 5 millimeter in case there is some collapse of the medial bone and our screws are not exposed and we get sufficient air. So that's very, very important when we are planning our fixation of the proximal humerus. Another important thing is we are looking through a very small window when we are talking about minimally invasive surgery. All the structures, they are not visible to your eye. You really have to imagine where these fragments are lying, how to reduce them, how to manipulate them and bring them in this normal position. From the knowledge of our anatomy, we understand that the supraspinatus and infraspinatus are attaching on the greater tuberosity. If my greater tuberosity is fractured and separated, it must be lying somewhere superiorly and posteriorly behind the head of the humerus. So from where we have to catch it and bring it to its normal position. And if there is attachment of the subscapularis on the head or on the lesser tuberosity, that will be going into the medial side. So we have to catch it from there. So it's very, very important to understand where these fragments are lying because you will not be able to visualize them. You have to imagine and catch them from where they are. It's important to understand that. Another important aspect is many of the fractures, they come like this. These are called the valgus impacted fractures. And on X-ray, we judge that it is an undisplaced fracture. Actually, it is not. You have to have a CT scan to understand this. Actually, the head of the humerus is pushing between the two tuberosities and tearing them apart and impacted over the shaft, the metaphyseal part of the shaft. Unless you disengage it from there, it is not going to come back to its natural position. Tuberosities will not reduce and you will not get the good outcome of the shoulder surgery. That means if you see any fracture like this or valgus impaction fracture, don't fix it in situ. It has to be reduced to good to give your patient a good functional outcome. That has to be understood. Ultimately, the principle of treatment is we want a good articular reconstruction, especially two things. One is the greater tuberosity, because it has been seen that if your greater tuberosity is uniting properly in an anatomical position, it is directly related to your functional outcome. So we have to make sure that greater tuberosity is reduced well and it unites. That's very, very important. And the medial hinge is intact. If your medial hinge is gone, medial hinge is not intact, ultimately the varus strain will be too much and the varus collapse and medial loss of the fixation will take place. So these two things are very, very important when we are dealing with this proximal humerus fracture. And ultimately, as with any periatrial fracture, you have to provide a stable fixation. You should remain minimally invasive as far as possible, doing least trauma to the fracture site. This is debatable, but when we are talking about minimal invasive surgery, this is important. And our fixation should be good enough to mobilize our joint early. If after surgery you immobilize your joint, you are going to get poor results. So that is very, very important that we have to make sure that we have given sufficient stability to the fracture construct so that we can immobilize these joints very early for good functional outcome. Surgical approaches, deltoid approach is a classical approach which we have been seeing since our college time. Teaching, we started with that. Transacromial is a theoretical approach now, most of us don't use it. But deltoid splitting, whether a regular deltoid splitting or a deltoid splitting, minimally invasive approach that we will be talking about now. The surgical approach I will be taking is the minimally invasive or MIPO anterolateral deltoid splitting approach. And the advantage is you are working right over the tuberosity. Tuberosity is in front of you and you can just catch it and fix it, and your plate will be applied over the tuberosity to provide additional stability. It has been proven in literature that the anterolateral approach gives lesser chances of AVN when you compare it with the deltoid approach, and my approach will be minimally invasive, hence doing less trauma to the patient shoulder. We'll be working basically in this area, between the anterior fiber and the lateral fiber of the deltoid. Entry from here, we'll be entering into the deltoid bursa and we'll open that bursa. Yes. We'll open this bursa and then work inside. You can see the exit nerve is lying somewhere. It is approximately 5 centimeters from the lateral margin of acromion. So we must remember it in our mind that we should not go in that area. And as soon as you enter the bursa, you can, from the inside of the bursa, you can feel that axillary nerve and you know where it is lying. So it's not that difficult to identify that and to protect that. So if you know it is lying there. Classically, the retard splitting approach will go from here, mid of the lateral fibers. But I would prefer to go from junction of the anterior and the middle third. There's a logic behind it. When you are taking your sutures, the subscap suture especially, if you enter from here, it's very difficult to locate the lacetic velocity subscap from here. So if you taken your decision far anterior, then it is easy to get that suture, and posterior suture that the greater tuberosity and everything can very well be taken from both the incisions. This is my incision, approximately 3 to 4 centimeter from the lateral edge of the acromion. Whether you are going to do a small plate or even if you do a longer plate if required or dictated by the fracture itself. This is my distal end of the plate where I will be doing the fracture fixation. Stabilization modalities, multiple modalities have been used in the past. Almost everything people have used and everybody claims good results. But I must say that if you talk about the standard, in today's world, the standard is a fixed angle locking plates for the proximal humerus fracture, displaced proximal humerus fracture. Even with a fracture like this, I think one of the worst kind of fracture you can have in the proximal humerus, it can be stabilized and you can get this kind of result if you do it well and follow the principles of the fracture and you are lucky enough to get a good healing. Investigations, we go for the basic X-rays as we do in all the cases, but the few views which are important to understand the fracture displacement better and to see the whole configuration of the proximal humerus. These two X-rays there, this is a glenoid view and this is actually a scapular view. In glenoid view, your plate is perpendicular to the axis of the glenoid, and in scapular view, your plate is perpendicular to the axis of the scapula. So you are able to see the two views very clearly and you are able to assess your fracture with. The rest of these two views which we have taken, it's very difficult to do these views once patient is in acute fracture. May not be possible. In today's world, in periarticular fractures, 3D reconstruction is standard. Many times, X-rays are very misleading and you are not able to judge these fractures very well unless you have a 3D reconstruction. With a 3D reconstruction, what is most important, you are able to judge where the vertical fracture lies. Here, this is the lesser tuberosity, this is the greater tuberosity. I know subscap will be somewhere here and rest of the rotator will be there. So I'm able to pull them in and I can stabilize and reduce them. As far as positioning for the surgery is concerned, it is very, very important that you should be able to take two views of your proximal humerus without moving your patient, without moving the arm. Otherwise, rotation is lost. If you try to rotate the arm and see the lateral view, your reduction will be lost because these are very unstable fractures and you will not be able to do it. So it's important to get both these two views in the same position when patient is lying. And how it is done? You keep your patient to about 40 degrees of inclination. You are operating from this side, image is on the other side, and once you place your image perpendicular to the patient's body, this is your AP view or glenoid view you have seen, and then you switch to the other side, 90 degree to this axis, and you are actually seeing the scapular view. So both the views, you can see the true AP and true lateral view of the proximal humerus without moving limb, without moving the patient. You just change the axis. So what I do before surgery, I see these views, mark the angle at what AP will be visible and lateral will be visible. Just note it down on a chart, and my assistant or technician knows that when I say AP, it is 30 degree that, and when I say lateral, it is a 30 degree on the opposite side. Supposedly, it is 30 degree. So that helps a lot. I'm not fiddling between the surgery, and I'm very confident I'm getting the proper views. The step of the reduction are the same as with any periarticular fracture. You reduce the fracture as the first step. to best possible anatomical position, temporarily stabilize with the wires. This is the most important step as far as this surgery is concerned. You take sutures into the subscapularis, supraspinatus, and infraspinatus muscle. Later on, we'll be passing these sutures through the plate and we can stabilize through the plate, and that will provide stability to my construct. I will not be hesitant to mobilize these fractures immediately. And finally, you put in a plate to complete your stabilization. So this is the incision which I am going to take. As I said, it is the anterolateral. This is the anterior angle of the acromion, and I'll be about 3 to 4 centimeters down from there. Somewhere here will be able to clear now. This is the fracture we are going to operate now. I think there was some issue with the video here, so I'll go back and try to play it from there. So this is the fracture we are going to operate, a 4-part valgus impacted fracture, and नहीं शेयर है नहीं स्क्रीन को पॉज किया कैसे होगा स्टॉप करके रीशेयर करना yes. This is the posterior angle, this is the anterior angle. This is the acromion border, and this is my intended surgical line. And this is where axillary nerve is there, and this is the insertion of the deltoid. Here we'll be taking our distal part of the incision, depending on the length of plate I'm going to use. Infiltration of the subcutaneous tissue with epinephrine solution, because there's a lot of vascularity there. What is most important in this, whenever you are doing a minimally invasive surgery, you try to create flap. At least 1 to 1.5 centimeter beyond the incision site, you should be able to mobilize. This is your interval. I'm sorry, video is a little faster, just to save time. And between the interval, I'm just separating the muscle. And on separating the muscle, underlying this muscle, you'll be seeing the bursa, which this is the bursa. As soon as you open the bursa, you come to see the clot inside the joint. You clean that clot, and you are actually entering into the joint itself. And you can see that head of the humerus is right there. It was a valgus impacted, you are entering from here somewhere. So you can see the head of the humerus. You have to displace it, reduce it back to its position. I'm just feeling the axillary nerve, putting my finger inside. My axillary nerve is actually a centimeter down, so I have more space to move. Then I would like to disimpact the valgus impacted head. As I said before, until unless I disimpacted, tuberosities are not going to come to natural position. Once it is disimpacted, it is away from my operating field, or it is on the middle side, and tuberosities can fall back to its natural position. You can see that. Now the tuberosity has fallen back, head is reasonably positioned. All these things has to be checked in APL lateral view. I'm sorry, lateral views we have not covered here. Now I'm taking the suture. As I said, you retract anteriorly, leave the posterior part, try to take a subscap suture with a number 5 ethibond, and then coming to the posterior part, posterior superior, taking a helicis, pulling the tuberosity into the natural position, and then going to the soft area. It's very, very important to take the sutures into the soft tissue, not into the bone. Many of the people will do take a bite into the bone. Bone is very fragile. It will bite through or cut through. So it should not be done. You take the suture into the muscle, tendon itself, and then coming to the inferior part, that's a subscapular or infraspinatus area. So, subscap, supraspinatus, infraspinatus. All these 3 sutures are taken and they are just left there for the final time to the plate itself. Now these 3 sutures, they are in place, they are strong. I'm just pulling them, just checking the hole. And once these sutures are done, now we have to reduce the fracture and do the temporarily stabilize with KOA. We have reduced it. It's important to remove this incised rib from there, otherwise it gets trapped in the wire itself. So we will be entering from this shaft and we'll be going to the head. So we checked the reduction of the head only. I'm not bothered about the greater velocity right now. We'll put 2 K wires into the head from the shaft so that now the head is stabilized over the shaft itself. Once these 2 K wires are in place, at least now this has become one unit and we'll be coming to the tuberosity. Now we try to pull the tuberosity down and anterior as it has gone superior and posterior, and then fix 1 K wire from above downward, entering from the greater tuberosity and exiting over the medial calcar area. So these 3 K wires will hold the fracture together in the anatomical position, and then you can proceed with the final fixation. It's simple now. Reduction is done, temporary stabilization is done, you just have to apply the plate. All of us have applied the plate so many times, there's nothing much. There's a little trick. You elevate the bursa, put a soft tissue elevator under that, lift the elevator, and you put plate under that. So your nerve is protected every time. Once you use your finger, you are elevating nerve with the finger, and surfer is going between the finger and the bone, and then you are putting plate between the surfer and the bone. Every time your axillary nerve is actually protected. So you are not doing any harm. Once you enter the plate halfway through, you pass the sutures in the respective suture holes in the plate, and we leave them after passing by. It becomes very difficult once your plate is seated and you try to pass these sutures. So you just pass these sutures and don't tie them, just leave them on the sides. All these 3 sutures, they are taken, subscap, supra and infra, and then you try to seat your plate to your desired level. Once you seat the plate to the desired level, put in a K wire into the K wire hole on the plate and check the level. I'm happy with the level. My plate is sitting well below the tip of the greater tuberosity. And then at the end of the blade, we create another incision and put 2 homans, one anterior, one posterior. And my plate will be centered between these 2 homans. There's no way it can go. There's one anterior and posterior homan to protect it, and plate is in between. And once it is seated well, I'm happy with the position. We just fix it with a drill bit of KY to keep the plate centralized on the bone itself. Now all the fixation is done. Plate is well central. Next thing I would like to do, I want my plate to seat better on the humerus. I'll just put in a cortical screw next to my last fixation screw and tighten a cortical screw over it so that the plate is seated on the shaft. We have not done any fixation on the proximal side. So once you do that, your plate is actually buttressing the proximal area more. It is pushing the head towards the middle side, and normal contour of the head will be maintained. Once that is done, you can go for the fixation on the proximal side. And it's important when you are doing the fixation on the proximal side that once you remove your drill bit, I use KY on the proximal side. Once you remove that KY, put another thin KY in the hole itself. The purpose is it will keep you guiding when you are putting your screw, because it's very easy in the proximal humeral area to get into a wrong direction, and then your screw will not work. So likewise, you put all these screws and check every screw in AP and lateral view, and later on by rotating the shoulder in all the directions. So the commonest error with these screws is they are inadvertently put longer than what is needed, because you are trying to go more medium. So that's important. And all these screws are put, 4 screws. These are transverse screws in 4 different directions. This is the last screw we are putting. Same way as we have put the other screw. And then comes your calcar screw. We are putting a locking screw in the distalmost hole. And then everything is good. I'm okay with that. I'll be putting a calcar screw now. That is the tricky part, because the calcar screw is going somewhere from here, and your axillary nerve is passing here. That is why many of the people they don't put this screw, but this is wrong because if you don't put a calcar screw, the construct is not that stable. So it's very easy to do that. Now your primary fixation is done. So you just abduct your arm fully. As you abduct, your plate is going under the acromion and the area of the calcar screw attachment is in front of you. So you are not damaging anything, you are not putting any traction on anywhere, and you can put that calcar screw. So that is not a problem. That should be the last screw to put. Once you stable shoulder fixation and you are able to rotate and attach it. The last thing is now we just tie these sutures over the plate to provide a stable construct to rotator over the plate. Normally you take 3 sutures. Many of the time in older patient, we have seen that there is a cuff tear also in the same patient. It is an older cuff. So we just repair it, that cuff over the plate, over the bone, whatever we feel like. That we have done in the same setting. It hardly takes 10 minutes. So that can be done. And you have a strong suture plate there to help you out in those cases. And the last thing would be to check the movement of the shoulder and different positions on the X-ray or C-arm, rotating the head and making sure that it is stable and there is no penetration. So that's very, very important because that is, if any of these screws penetrated, that is a real mess you have created and the patient will have problems. The closure is very simple, there is hardly anything and very quick. You just approximate the muscle, few sutures, and you get away with this. I think it is sorry. If you really follow these steps properly, you stabilize your cuff well, and reduction is anatomical, your healing of the tuberosity has taken well, and you are lucky enough, you can get this result in every case. I must have done more than 300 cases like this, and I'm really happy with this approach. I don't do it pectoral or routine primary focal fracture in hospital. It might look a bigger passing through a very small incision, but it is very much possible. Thank you very much.
Thank you, Dr. Sanjay Srivastava, for a very nice talk. Excellent presentation about repo technique for proximal. May I now invite Dr. Mukesh Jain. He will be presenting his talk online.
Yes, Dr. Mukesh Jain will be joining online for his talk on terrible triad injuries. Good afternoon, Mukesh Jain, sir.
Good afternoon. Good afternoon, sir, everybody. We are already late, so I will go through the terrible triad. See, this terrible triad means it's terrible fracture. Is it a fact that the lot of injuries around elbow, this terrible triad having around soft tissues, about tendons, about fractures, about dislocation. So that is the reason it is called as terrible triad. But when you understand this injury, it is not so terrible. It becomes so easy if you just understand the mode of injury, and if you treat accordingly, then it is not so terrible. Now here, the patient is having a fracture dislocation where lateral collateral and medial collateral ligament is gone. There might be extensor injuries to the flexor origins. There might be extensor and flexor, both injuries can be there. Usually it is the extensor which is more common, but you can have the flexor like pronator, etc. They can be injured. And then you have a coronoid fracture, and then you have the radial head fractures. So this whole combination is called as terrible triad. Now, radial head fracture is the most common fracture around elbow. We all know about it. And this fracture can be because of fall on outstretched hand with or without a rotational force. Now, you can have a fracture because of shear, you can have a fracture because of compression, and you can have a fracture because of the rotation. So when you have a fracture of the head rotation along with the rotation of the forearm, then probably you get these terrible triad injuries. So now what happened? The pathomechanic classification. If there is only shear, then you have a simple shear fracture. If there is a compression, like you have the Essex opacity, then it's a different kind of fracture. But when you have the rotational injury, then you have the injury to the capsule, you have the injury to the ligament, you have the injury to the coronoid, and along with that, you have the dislocation of the elbow. So this is important to understand that these are the rotational injuries. Now, if you see that axial load on the forearm in the supination form, and when there is a valgus movement on the elbow, what happened? That this is in a normal position. Now the injury starts, it starts supination, and then it is pulsed outside, and then ultimately it is dislocated. So this is the way it goes on. Now the mechanism is that there is a axial load on the forearm in a supination form, and there is a valgus movement of the elbow. Then what happened? Then LCL and the common extensor origin are torn. The radial head fracture is in a variable size. It may be in 2 pieces, it may be 3 pieces, or it may be furthermore comminuted. And along with that, you have a small coronoid fracture. Now, if the injury goes further, then you can have an injury to the MCL, or you can have injury to the common flexus muscles, or you can have injury to the both. If you have injury to the both, like MCL and the common flexus, then it becomes a highly unstable situation. But if you have injury to the MCL, but your common flexors are intact, probably it is a very, very good situation. In those cases, the MCL heals if you don't have the injuries of the common flexus origin. And if you have the injuries to the muscles also, then highly unstable. In those cases, probably you have to repair the MCL also. Now, there might be another mechanism, which is a direct posture mechanism. In this case, forearm is driven directly posteriorly. There is a coronoid fracture, which is a larger piece in comparison to the rotational injury. And the radial head, usually the anterior half or more of the radial head is sheared off. And along with this, you may have the olecranon injuries also. But only good part is the ligament and capsule injuries are much less in the direct posture mechanism. That is the difference between two mechanisms. In first mechanism, you have more of the ligamentous injuries. In this mechanism, you have more of the bone injuries. Now, if you just consider the MCL and the radial head, they provide you valgus stability. So you have to have a radial head to get a stability, and similarly, you need a medial collateral ligament. But for varus, what you need a LCL intact, and then you need a coronoid, which provides you stability for varus. So these two structures, LCL and coronoid, they provide you varus stability, and on the other hand, the head of the radius and MCL that provides you valgus stability. Now here is a patient who is a 42-year-old man, fell on his bike. He had isolated trauma. It is a non-dominant arm. Neurovascular structure was intact. Now if you just see the lateral X-ray, you can find out there is a small comminuted coronoid fracture. Then you have the radial head comminuted fracture, and there is a dislocation. You can make out on the lateral axis a lot of things, but at times you cannot see these small coronoid fractures. Now the 3D will give you a real picture. You can make out that the half of the head is not visible here. And if you see here that the half of the head is comminuted, it is lying anteriorly into 2 pieces. And this is the coronoid process which is sheared off from here. And now if you just see here, this is the coronoid process which is sheared off, and these are the 2 pieces, the head of the radius. Now the good part is that the sublime tubercle is intact. So the medial collateral ligaments looks intact in this particular case. So we have a shearing forces which has sheared the coronoid, which has caused combination of the head of the radius. So what we need buttressing of these two. We need a buttressing of the coronoid. We need the head to be replaced or to be fixed. Now, in this particular case, what we are going to plan, the lateral exposure, which will be the coccus interval between the anconius and the extensor digitorum, And then because it is comminuted, it is said that if it is more than 3 pieces, it is better to go for a radial head replacement rather than fixation. So since it is a comminuted, we are going to replace this. And then there is a large comminuted coronoid fracture, which will need definitely a fixation by screws or by wire or by ethibond or by plate, depending upon the size. And after that, once you do all these things, the most important thing in these cases is the formal repair of LCL. I think that is the crux of your stability. Once you fix your head or replace your head, once you fix your coronoid, the most important part is the LCL repair. Now you can make out that the treatment principles, we want to restore the stability. That is the most important thing. And we want to protect this reconstruction. Whatever you have repaired, we want to protect it. We don't want that we lose it. And then you allow early range of the movement. But the important thing in terrible triad is stability, and protection should take precedence over motion. You cannot say that I have repaired it and I start the immediate movement. No, your stability has to be more important. If you have a good stability, then definitely you will have a good range of the movement. It will be painless, free painless movement. But if you have an unstable elbow, if you start mobilizing, you will have a stiff elbow. So it is very important to provide a stability. The non-operative treatment, yes, sometimes it is indicated when fracture is minimally or undisplaced. You have a good reduction and there is a stable arc of motion more than 40 degrees in extension. If you have that, then probably if you have reduced your fracture well and you feel that you can have a good stability, you can treat them conservatively in a POP splint. Now, coming to the algorithm, the first important thing is once you have the terrible triad injury, you look after the head. Whether the head has small fragments, more than 3 fragments or less than 3 fragments. If they are fixable, please fix it. If they are not fixable, then you replace them. Now, coronoid fracture, if it is a smaller piece, you can ignore. If it is a larger piece, in that particular case, either you fix it with a retrograde screws or with the help of the threaded wires or with the ethibond, or if it is still larger, then you can fix a plate. And lastly, once you have fixed your coronoid, once you have fixed your head of the radius, then you have to do the formal repair of the LCL complex. And even now, if you see that there is no stability, then probably you consider external fixator if there is a persistent instability. That is very important. So this is the algorithm for terrible triad. Now we take this patient for surgery. This is the Cocker's incision. All of us, we do in almost every day in all the elbow cases, wherever we have to fix capitulum, we have to fix the head of the radius, or many other surgeries. And this, as soon as you do this incision, many times the lateral collateral ligament is already torn, and you can visualize the head is lying just below subcutaneous tissue. So you get a direct exposure. If it is not exposed, then you take the Cocker incision. You take incision between the anconius and extensor digitorum, which usually you start your dissection from the distal side rather than coming from the proximal side, because it is very easy to delineate between these two muscles. And then once you do, immediately you see the head radius, you can just elevate your head radius. And once you have done, you can osteotomize the head of the radius, keeping this in mind that you're going to replace it. So you have to be very careful that how much you have to cut the shaft. And once you have done it, you take out all the fragments, because until unless you take all these fragments, you cannot measure the size of the head. So this is very important. You take out all the heads, assemble them together, and then decide that what size you need. Then you already have a coronoid fracture. Now this, after this incision, you can go on the anterior side of the coronoid, and you can catch hold this coronoid process with the help of the wires. And then once you have you have fixed your coronoid process, it depends upon the type of fracture. If the fracture is a good quality fracture where you have a solid bone, probably you can put screws. If there is a combination, so at times it becomes difficult to put the screws into that small fragment. In those cases, you can put a threaded K wires, 1 or 2, so that you can hold it in position. And after that, you just go for the head radius replacement. It is very simple that you drill it, you make out a hole into the shaft. And once you have cleaned it, the shaft, like you do the all in the cementing, you do the cementing. Cementing you have to take in a liquid phase so that you can push into the shaft. And then you check with the trial processes. And after that, you can put your original processes. Now, once you have completed your processes, you have done your coronary fracture. Now, the important thing comes about the LCL complex. And this LCL complex, the most important thing, you have to find out where it was the attachment of your lateral collateral ligament. And this is the rotation. For this capitulum, this is the center of the rotation. So you just visualize that this is the center of rotation, and then you make two holes. One hole from the center of rotation to the anteriorly, and another hole from here to posteriorly. And then you can put these two vicarals just to make clear that you have already a hole anteriorly and a hole posteriorly, so that you can pass your lateral threads through the same channel. Once you have done is, then the most important thing is this anterior part of the muscles and the tendons and the capsule, and the posterior part of the muscles. So these are two flaps, the anterior flap and the posterior flap. And these anterior posterior flaps, you stitch back from distal to the proximal. And once you come over here where the center of the head, the rotation is there, then you pass these threads through these two holes so that you can tie them exactly at the place where is the center of rotation for the capitulum. And then you do the wound closure. And this is your post-op picture. These are the two screws we have passed over the thread over the wires, and this is your head radius. It is properly placed. You have to check whether this head of the radius is not higher to the coronary process. That is the most important thing. It should be 2 millimeters down to the coronary process that you have to check on your C-arm. And these are a few cases where you can see that this is a patient, again, had a terrible triad fracture dislocation. Now, in this particular case, we have just passed two threaded wire because it was too small fragment, and then we put a cemented bipolar processes. Another case where you see that the fracture head is not communicated, it is a single segment, it is gone from the neck. There is a dislocation, there is a coronary process fracture. And this is a CT scan where you can see a very small piece of a coronary process. Now you can make out that already there is incision already there. As soon as you open the subcutaneous tissue. And now in this particular case, because the head of the radius was good, so we could pass these two screws and we could fix it very well. And then because the fractures was a very small coronary, so what we have done is we have taken an acetone bite, took it out and fixed around this thread with the screw under the washer. Now this is another case where there's a fracture head radius, which we have fixed with the wire, with the thread, with the screws, and then we have fixed the coronary process with the help of the screw. Now this is another case. Again, the coronary was too small, so fixed with the help of the acetone. Exactly in the same manner, we have put the head of the radius displaced and then take it out, acetone bite from the coronary process and the capsule, take it out on the posterior head of the ulna, and then fix with the help of the screw. This is another case where you have the fracture olecranon along with this. Now, this is the fracture olecranon. There is a coronary fracture. There is a head radius fracture also, and it is gone from the neck. There is a combination also. Now, this was done. The head was replaced again. The coronary was fixed with the help of this screw, and the olecranon was fixed the tension band wire fixation. This is a post-op picture. This is another case. Last week we have done it. He had a fracture dislocation elbow, and he had a fracture of the combination of the elbow and the radius. This is again treated in the same incision, in the same way. The processes were replaced, and it was the small coronary process was with the fixed with the threaded wires, and the radius was fixed with the help of the plate and the wire. So to summarize, the dislocation with fracture of the coronary and terrible triad can be very unstable. There is no doubt about it. But repair of the coronoid, restoration of the radiocapital contact, and reattachment of the origin of LCL to the lateral epicondyle usually restored stability. MCL repair is not usually necessary. If you have an intact pronator, I think you don't need to touch the MCL, but if it is highly unstable at times, you have to fix it, or you give a support of external fixator to support it. Thanks a lot. Any questions from?
Thank you, sir. We can have two questions. We are late. Any questions to Dr. Sanjay or Dr. Mukesh?
Sanjay, you have been extremely good. Sometimes the four-part factors, the article this article that goes far medially is the required of the cardon is the axilla. Very near to the neurovascular. How to deliver it for delivering out this? I'm not able to get any voice from there, so please be clear. What is the question?
I think we can have any question from Dr. Mukesh.
Okay.
Sir, this question was not for you. It is for Dr. Sanjay.
Okay. We have a question for Dr. Mukesh first. So, yes, Ravi, please. Then we can answer the question of the video. Ravi, yeah.
Sir, good afternoon, sir. So my question is that when we fix the LCL extensor compressed ligament repair, after that we check the stability for MCL.
Yes.
Yes. So when we do the repair of MCL, basically the ulnar collateral ligament,
Usually we don't repair most of the time because you don't get such an instability. But yes, at times, even after your repair, after fixing the head, after fixing the coronoid, if it is highly unstable situation and you feel there is a huge muscle involvement on the medial side also, in those cases you open the from medial side. But if you feel your pronators are intact, you don't need to repair the MCL. The protection will be given by your pronators. In those cases, if it's still unstable, you can put external fixator. There is no need to repair.
How do you assess the stability, the extensor, which
exactly.
How you assess the stability when you need to fix the MCL?
In extension, you just give a stress and you see how much is the opening on the C-arm. If it is a minor opening of the C-arm, probably you have a protection from the pronator. If you have a very high opening, which is opening up completely, then you suspect there is a ligamentous injury. And in those cases, probably you have to go on the medial side to repair it.
Okay. Thank you, sir.
Any other question to Dr. Mukesh?
I have one question. Sir, what do you believe that if the radial neck is also shattered along with the radial head, do you reconstruct?
Actually, if the neck is shattered, if you see the neck is shattered, if there's a combination, in those cases you have to use a plate, because otherwise you cannot get good fixation by help of the two screws. So in those cases, you have to maintain the length, you have to maintain the combination, and you have to fix it.
But suppose the head has more than 3 fragments. Then
in those cases, if the head is not fixable, definitely you will need a replacement.
So you reconstruct the neck.
Yeah, you just leave the neck as such combination. You just maintain the length of the head radius. So your head radius position should be 2 millimeter less than coronoid process. So which you can check during surgery also. You can check on the C-arm also, and you just cement your neck, you cement your processes.
Thank you, sir.
One question to Dr. Mukesh, please.
Sir, you can come.
Dr. Mukesh, this is Dr. Sanjay Srivastav.
Hi.
Hi. One question that what we saw that whatever cases you use the prosthetic implant on the head radius side, you use it cemented implant. My question is, there is growing consensus that these implants should be used as a temporary device because long-term complications of implanted radius is growing. So there is a growing concern that after some time these implants should be removed. So many of the surgeons, they are using an uncemented polished implant, which is actually not getting incorporated, and after some time, once we feel that the elbow is stable and functional results have taken place, then you remove that implant. What's your take about it?
Sanjay, my experience is very little. For 5 years, I am using these heads, and I must have done more than 100 cases of head replacement in terrible triads. Out of these 100, I can say in 2 cases, I have to take out the head because of, in one case, there was a lysis in the shaft. I have to take it out, and after that, the fracture was healed completely, but there was no head inside. And in second case, there was an infection where I had to take out. But in the rest of the cases, because this is a cemented one, there is no problem so far. But yes, you are right, because we don't have these good processes in India available. So for me, it is very difficult to find out the processes. These processes are available from Gujarat. I am using them. I am happy so far, but still there is a concern about it. I fully agree with you.
Thank you.
I can answer to your question, Dr. Chandan. When you have a comminuted neck along with the head where you need to remove the head. So if you have any comminution to 2 millimeter, replacement is the only choice. But if you have longer fragment of neck, only that part you can actually reconstruct. So there is smaller comminution, you cannot reconstruct that part of neck. But the trick is that you have to adjust between the height of your head radius which you are replacing versus the overall radius of the head radius which you are replacing. Because if you go larger head size which you are replacing to correct the length of the comminuted neck of the radius, then you may overshoot the size of the head radius. So you'll have to balance between both and then decide the size of the head of radius which you are replacing.
Thank you, sir. Any questions? That's one more question. So with this, we conclude this session.
We have a question from Dr. Tripathi.
Yes.
That's the last question.
The question was that fracture.
I think it's got echo correct.
The question was that how to manage fracture dislocation head where the head is lying deep and anterior to glenoid. If you talk about the traditional management, you definitely judge this pre-operatively and you go by the retropectoral approach, no doubt about it. I have done many cases where these fragments were lying anterior to glenoid and I was able to retrieve them from the lateral side with the same incision. The trick is that you place a long lining back retractor, thin one and long one, under the deltoid, under the bursa, and try to lift it. You place a LSS or a pointed clamp over the head, hold it, and third retractor goes between the glenoid and the head. So now you have created a skid on which you can slide your head out because it has gone from this side in, it can come out. I have a series of 5 cases which we did, but the issue is all these cases are very high risk for complications. The functional outcome is not very good. So I have a very low threshold if my patient is towards the older side to replace it. But if the patient is young and we really have a good bone stock, there's no option, we have to go and do it. In one case, we have to open it with mini incision retrofactorial just to slide that head backwards to the position. Although it's quite dangerous because we have not opened it fully and the neurovascular structure is very close. So that's what.
So Dr. Sanjay, what's the hitch in using deltopectoral approach from the beginning in such cases rather than struggling from a small window?
Absolutely. Absolutely. That's what I said. The first thing, you know it that this has happened. First case which I did, I missed it. Missed it because patient came with the X-ray and we were just go in for the surgery. We didn't get the CT done and we didn't get further investigations done. So I missed that. I thought the head is in Keynote, but actually it is fine there. So I have to struggle to get it out. So the first one, when I got it, so I started trying it in other cases. So that's the 5 cases we did. Even I have 3 videos of those cases made just to analyze myself, see what is going on. But frankly speaking, if I know it beforehand, it's better to go to the vet.
With this, I close the session.
Thank you, sir. With this shoulder and elbow session is finished. I will start hand and wrist session. I'll invite Dr. Rajendranath sir, Dr. Ashish Kumar sir, Dr. Vijay Saxena sir as the chairperson. Very good afternoon, Vikas sir.
Hi. Hello. Hi.
So I would like to introduce Dr. Vikas. Dr. Vikas sir is a senior consultant in the Max Hospital, Delhi, and he's a very renowned hand and wrist surgeon. His interest is basically the wrist arthroscopy. He has designed so many implants, so many plates for the distal radius, and we are honored that we are really privileged that today we have talked about distal radius fractures. What are the new things? What are the new implants? What are the new techniques by Dr. Vikas Gupta sir? So Vikas Gupta sir, kindly share your screen please and start your talk please. Thank you.
Thank you, Ajeet. Thank you for nice introduction. But like Kanpur, visited Kanpur first time was 2004. I remember Dr. Gadre was there. He welcomed. So I'll start with a tribute to him. And the topic given to me was recent advances in distal radius. So when I was going through the topic, I just got confused. What should be the recent? How do we decide the recent advances? So it is more than 200 years since Colles fracture was described. Even before the X-rays, Colles described the distal radius fracture. But in last 2 decades, it is the distal radius has taken a journey which is very, you can say, disrupting or very evolutionary. So let's see the journey of last 20 years, which will include all the advances. So we'll start with 1990. The reported outcome of conservative management by Shern was like 20 to 30% of the unsatisfactory results, which led many people to think that we should have something more than conservative. And as time was passing by, we were getting more and more high energy trauma. So need to fix the distal radius was seen. We all agree any fracture which is metaphyseal, you should have a right alignment, length and rotation. And in case of intra-articular fractures, there should be absolute and anatomical reduction and early rehabilitation. So if we see what should be done for these cases is first to achieve the reduction. If we have achieved the good reduction, we have to maintain the reduction. And after maintaining, we have to early rehabilitate the patient, as Dr. Mukesh Jain was talking. To get good functional result, the early mobilization should be there. So it should be in cases of intra-articular fractures, anatomical reduction, stable reduction, biological fixation, and early and active mobilization. It is just recap of fracture fixation of any type. So we'll start with volar bottom fractures. These are the fractures we started fixing, or everyone started fixing very early with plate. So LS plate was used. It was more of a buttress plate, but the prerequisite here was that dorsal cortex has to be intact. So it was mainly on the buttressing principle that under contoured plate and more straight plate. And as you tighten your metaphyseal screw, it will give compression at the intra-articular fracture site. So this was one of the article in which we published JBJS American, that this is the fracture where you don't require a locking plate, only buttress plate or non-locking plate would do. This was like, I think 2006, but let's start our journey in 1998 when we were doing a lot of buttress plating. So many times we used to miss a dorsal fracture, undisplaced fracture, and it would result, this is our case only, this would result in malunion, something like this, very embarrassing situation. So that was a time 2003 when fixed angle, 2003-2004 fixed angle construct plates came, that is locking plates came. So in locking plates, the screws support the articular surface. So you have multiple screws. They act as a raft under the articular surface. So it prevents them from collapsing. Therefore, need for bone grafting is reduced. And in osteoporotic bone, the fixation is good. So this was it. So this is 2004. We had a discussion in New York symposium, biomechanics symposium, that at that time there were around more than 40 different types of distal radius plates, which were, some of them were biomechanically more than 10 times the physiological load. So did we need so strong plate or so many design, or was there so many things were there? It caused a lot of confusion in younger colleagues how to choose an implant. So choosing an implant, most of the things, locking plates are more rigid than any locking plate, and different companies gave a different constructs, but they offer similar biomedical properties. So there are few things here and there which are different because of reasons of patent laws and other things. So they were similar biomechanically. So being part of a few designer team also. So actually there's not a lot of difference between the plates designs. All of them had a good rigid fixation. But with the advent of variable angle locking plate, the versatility of fixation was added. And there are some specific designs we'll discuss in coming slides. So this was 2004, when first time in country we started using 3.5 locking plate. If you see this plate, the screws were 3.5 mm. So you maximum 3 or 4 screws could go on the articular side. So this was one of the big disadvantage. But at that time also, if you use right principle, you can do things correctly with simple plates like this. So this is 25-year-old male with road traffic accident. Let's discuss the X-ray. There is a dorsal tilt. There's an increased height. There's a splaying and increased height of the increased width of the radius on lateral view. There's a die punch fracture. Lunate is driven into a radius. There's a radial stellate fracture. There's a ulnar stellate fracture. So if you are treating, if you have to address, you have to address most of these things. So fracture, CT scan confirmed our finding. It is an intra-articular fracture. There's a dorsal fragment. There's a metaphyseal combination. So what we did, we just opened from the dorsum, and splaying was taken care by just single screw, just like interfragmentary screw. So after single screw, you can see there's a good reduction. Only radial stelloid is which shows instability. Otherwise, radius looks good. Then we went, same patient, we went from the bolus side through the Henry's approach and fixed the distal part. Then we fixed the distal part of the plate with the help of the locking screws. And you can see that this is the plate which is fixed distally, and there's a gap. Once you press with the thumb, you can correct the tilt of the radius. So this was the fracture. So this is very old. We are talking about 2004, where today's implants were not available, but using those principles, we could get fixation. And ulnar stellate fixation was also done with the help of single screw, and ethibond was used as a tension band. So this was the same patient in which locking plate was used, and contouring was not done accurately. And this was same patient, volar dorsal and medial incision. So 3 incisions on the wrist, and good result was there. Then in 2007, we have the juxta-articular and extra-articular 2.4 system. So this was first time it was used in 2007. So advantage here was that screws were 2.4 locking screws. So we had more number of screws to fix the distal fragment or articular fragment. So this was the case, few example. So that time there were 2 plates. One was extra-articular for the proximal in which the metaphyseal fracture was there, and just a articular plate was there for the fractures which are intra-articular or distal fractures. So this is how you used to fix. You get a good fixation in the distal fragment and get a good, you can see fixed angle device which acts like a raft under the articular surface. So articular surface is supported by these fixed angle screws, and need for the bone grafting was reduced. Otherwise, all these fractures we were bone grafting earlier to prevent the collapse. But if fracture is distal and fixed angle device, you can have problem something like this to just to get a buttress under distal fragment. You can have articular screws which can go into the articular, intra-articular. This is the arthroscopic view of the same patient. You can see the screw which is intra-articular, which has not only damaged the radial articular surface, but lunate also is damaged. Lunate surface is also damaged. So in such cases, variable angle is very useful. In this, we can rotate the change the direction of 15 degrees in either direction. So actually you get a 30-degree cone in which screw can be placed. So you can change the direction of the screw proximally, laterally, distally, depending on fragment. So you can go for a more fragment specific fixation, and you can fix the fragment, and number of screws were more because there were 2 rows. The second row ulnar and radial screw was there to give more number of screws to give versatility fixation. So case like this, to a 27-year-old male had a motorbike accident, a compound fracture. Initially, same night, patient was taken up for the surgery, external fixator applied, a debridement done. And then second look was done after 5 days when we thought that wound is good. And at the same time, the fixator was on. We did the fixation with the plate. So plate was used here because of combination. We took a reference of a ulnar fragment because ulnar here, length of the ulna was restored, already restored. So you take a reference from here, then we build our reduction in the articular surface on the lateral aspect. Then we give the support, fix other screws like this to get a good fixation intra-articular. So at the same time, the resurfacing with the ALT flap was done. So because if we do the flap and then wait for flap, we waste 3 to 4 weeks. So we did fixation and flap in the same setting. So this was a patient. We retained the fixator just to get an extra stability. Plus, patient had fracture in the metacarpals also. So we needed so there was a plate, there was a fixator, but ulna went into non-union. So same patient, we did a plating, bone grafting of the ulna. At the same time, Adam Verger procedure was done to stabilize the DRUJ, distal radial ulnar joint. This patient was a pilot, and he passed his fitness test after all the reconstruction implant removals. After 21 months from the surgery, all the implants were removed. So patient had a good functional recovery. So from here, over the almost 2 years from here, we went to this place, fixation of the metacarpals, mobilization. There was a tendon injury also, tendons were also repaired. So this is what you have to be very aggressive when there are multiple fractures or open fractures. Otherwise, hand function is lost. If we go by the traditional external fixation, wound healing, then do the fixation, by that time, a lot of stiffness is there. So another case of distal radius fracture, comminuted fracture, metaphyseal combination was there, fixation with the plate was done, and the post-op X-ray, you see something like this. It worries a lot of people who are not trained, or if your X-rays are not good. Initially, a lot of my cases, a lot of people got CT scan done in the post-op to see whether screws are going intra-articular or not. It is just the view. So same patient, we change the view. As you change the view, you can see when you focus that this is your volar surface. This is your distal is your volar surface, volar cortex, and distal part is your dorsal cortex. So any screws which are going in between these are intra-articular, otherwise you're safe. So you have to read your x-rays properly, and you have to get tell your technician to take proper x-rays. Same patient, the change of the view can change a lot of things. So, but why we have to go so distally to get the screw subarticular? Because maximum purchase you get is in the subchondral bone. So your screws, for better fixation, your screws should be subchondral to get the greater stability. So you cannot be just to play safe, you away from articular surface, then your fixation will be compromised. So you have to work in a very narrow margin. Then fractures like this, this plate came to, with us in 2012 when we did this volar rim plate. Though it is not any advancement, it is just a plate for very specific situations, because it is one of the plates which goes beyond the watershed line. It goes beyond the watershed line, and screws are directed towards metaphyseal proximally. So this is how the plate looks like, and this is why it is bent. So this is where watershed is there. It is going beyond the better watershed, and it is bent anteriorly so that your attrition of your FPL and FDP is minimal. That is how this plate is designed. So it is only for very specific fractures which are volar lip fractures. It is volar, that is why it is called volar rim plate. Only thing is, many times there is a tendon irritation. If you're not careful, your screws can go in the joint. So this was 36-year-old male, had a multiple polytrauma, pelvis, femur, tibia, etc. Everything was fixed. After 10 days, patient was referred to us for fixation of distal radius. So we got the CT scan done. As you can see, the distal fragment is very small. So fracture line is very almost till the rim. So you place the plate and get the temporary reduction. To the plate, you pass your wires. In the C-arm, you see whether your reduction is good. Once you're satisfied with your reduction, then you pass your screws. So initially, K-wires help you to seat the plate very distally. Then you can do the fixation with the help of your screws. This is something like a home run screw, which goes from the metaphysis to the tip of the dorsal tip of the radius. This is the most important screw which prevents the fracture from tilting dorsally. Single screw which helps us a lot. So this is how you get a fixation in the distal part, you get a fixation in the metaphyseal part, get up to the dorsal cortex, and this is metaphyseal fixation. So in this case, we didn't use bone graft, just fixation of the fractures. So you have to make sure your alignment is okay, your joint leveling is okay, you're not ulna plus or ulna minus. And if everything is good, then you can mobilize the patient early. Then we started doing wrist arthroscopy. Wrist arthroscopy helped us a lot, because now you can reduce your fracture fragments, and your limit was set for less than a millimeter step. So whatever step which you could do from indirect reduction, you can improve it. But at the same time, you could treat your THCC also. So we did one study, MRI study, in which we found that more than 50% of patients had an associated THCC or ligamentous injury along with the distal radius fractures. And with this, we can treat these injuries, ligamentous injuries, at the same time. You don't have to wait for things to heal and take the patient for any other surgery. So same patient, distal radius was done, THCC was done in the same setting. Another case, bilateral wrist trauma, in which there is a fixation, metaphyseal intra-articular fracture. There is a scaphoid unit, cap is there, scaphoid unit ligament. Other side, there's a intra-articular distal radius with the big chunk of the radial styloid. in this case, arthroscopic assisted fixation was done, as well as scapholinate ligament stabilization was done with the help of K-wire. And you can see, that THCC was repaired at the same time. So we don't take care of anything to the bone. We just repair the THCC to the bone to give additional stability to the DREJ. Another case, 27-year-old male with a metaphyseal fracture. You can see that there's a fracture from the base of ulnar styloid also. So you fix the here we took the lateral side as a reference point. So we fixed with the K-wire temporary fixation of the radial styloid, and then plate was put and radial styloid was fixed with the help of screw. Then you can see that there's a step which was taken care by elevating under the metaphyseal fracture.
Because we are lagging behind, so
okay, I'll just conclude then.
Yes.
So arthroscopic reduction was done for the same fracture, and this was I'll just metaphyseal fracture, same fracture, pre-op and post-op X-ray. Last slide, I'll just conclude. So there should be a stable fixation, early mobilization for the distal radius fractures. Locking plates prevents the late collapse, and that results in better result. Arthroscopic assisted fixation leads to better assessment and reduction, and associated injuries can be taken care. Thank you.
Thank you, Vikas sir. We'll have question in the end of the session. Okay.
The next is management of neglected PIP joint injuries. Dr. Bhardwaj.
Praveen sir. Praveen sir, very good afternoon. Praveen sir, you're not audible. Please unmute yourself. Please share your screen, sir. So I would like to introduce Dr. Praveen Bhardwaj. He's a senior consultant in Ganga Hospital. He's a editor of the Asia Pacific Journal of Hand Surgery. He's excellent. He's extraordinary surgeon, as well as he's one of the best teacher I've ever met. And I'm proud to say that I'm a student of his, and he's my teacher. He's my mentor, and he's one of the amazing teacher who teaches us about the hand surgery. So most welcome, Praveen sir, on this webinar. So kindly start your talk, please, sir. Thank you.
Thank you, Ajeet, for a nice, very sweet introduction. Since we are going late, I will just straight away go on to the topic. So we'll be talking about neglected PIP joint injuries. Now, when we talk about the PIP joint injuries, the neglect could be on part of the patient, which is quite common, because most of the patients feel that the injury is very minor and they just keep playing or keep using their hand for activities, and when they feel that the hand is not getting better, only they come to us. At times they would have gone to a treating doctor or even a physiotherapist, and he feels like, okay, the injury is not much and we can manage it just by observation or putting some ice. But often it is because of both. And many times neglected is not a very good word. So I would like to tell them at late presentations. And this could be on part of the patient or a part of the doctor. Now, one of the most striking example of delayed presentation is this doctor who is a eye surgeon, ophthalmologist, who had this injury. He is an enthusiastic biker. And when he fell down from a bicycle, he had this injury and he felt like it is nothing much. He just himself took an X-ray and these x-rays look quite okay. And he felt still the pain was there. Again, he went to an orthopedic surgeon who saw a small chip fracture, so nothing to worry. But still, if you see, there is no proper lateral view was taken. And only at 10 days, when a proper lateral view was taken, we can see that it is not that simple injury. There is a bad comminuted fracture of the base of the middle phalanx and dorsal subluxation at the PIP joint. For an ophthalmologist, middle finger, it is a big problem, because if he is not able to have a tripod pinch, he will not be able to do his activities like operating. And after seeing this, he was given this type of ball bandage. This at times work, but it is really not a good type of treatment, especially for a high demand person, a surgeon like this boy. So we took him up for surgery, and we saw that we were able to get a good reduction, and we applied this Suzuki traction frame for him. Just to give an idea of what is this frame, this is a very innovative technique described by Suzuki, in which there are wires put at the proximal phalanx and at the base of the middle phalanx. You can see the wires are put in such a way that when the rubber band is put, it causes a distraction at the PIP joint. So if you can see, the hooks are facing distally in the distal wire, and they are facing proximally in the proximal wire. And when a rubber band is put, it compresses the two wires in such a way that you get a distraction at the PIP joint. And this distraction is the same principle what we very frequently use in orthopedics for treatment of various injuries. After putting this Suzuki frame, we can see we could get a good reduction. And in the lateral view, the dislocation is corrected. The small bony chips have fallen down in place. And even on full flexion, we can see that the concentricity of the joint is maintained. And this patient was a nice boy. And you can see while going home itself, he was started on movement. This is the video he sent in his car that he is doing the exercise. And this is at 4 weeks. He required a lot of hard work. This is background. We can see the hospital. He is even working over there. And because of his good exercise at 6 weeks, he was back to his normal enthusiasm of cycling. And he had perfect range of movement of this kind. We can see it's got full extension of the finger, full flexion of the finger, and he was back to normal activities. So though there was a delay in presentation, but by the modern techniques, we were able to get a perfect outcome in such a patient. So first and most important thing in preventing missing such injuries to suspect and have a perfect lateral view. If we have a good lateral view, I think the half of the problem is solved, because lateral view is quite striking, and anybody can detect that there is a fracture which requires some addressing. In acute injuries, there are a lot of options, and I think all the options work quite well in a satisfactory experienced person. And any one of these options can be chosen, right from a close reduction, dorsal splint, or open reduction and fixation. The basic thing is we should be able to restore a joint space. We should be able to correct the subluxation, and we should be able to introduce early movement. So even if we are managing with a static splint, we should move these patients within 2 weeks. And if we are able to put a dynamic fixator, that is even better. Now, when presenting early, even a very complex fracture like this can be managed by just a small traction splint like this, which we commonly use at our hospital, called a Zimmer splint. And within 6 weeks itself, you can see the good result. We have done hundreds of these patients when they present acutely, and recently we have published our results in Journal of Orthopedic and Joint Surgery, and it is very reliable. However, this simple technique works only when patient has presented within first 1 week or maximum 10 days. So anybody presenting late, the problem is the joint would be stiff. The reduction is not possible. You require a little more force to reduce the joint. And maintaining reduction is more difficult because of the stiffness. So even if you are able to get reduction, a mild traction, if you put, it will just slip away again. So you require a little bit harder force to pull at this stage. And also the comminuted fracture like this, the bone fragments will be very friable, will not be able to handle to fix them. However, if the fracture fragment is quite big, even at 4 weeks, we can do an internal fixation as we did in this case. This patient was around 3 to 4 weeks after injury, and we opened up and we cleared off the fracture site. We could fix with 2 screws to get a good result like that. However, most of the times the fragment size would be small and there would be a lot of combination of this fragment, so it will preclude any internal fixation. In such cases, the philosophy what we go by is, if patient is in 4 to 6 weeks duration, that is the commonest presentation what anybody would have, because a local treating person, even if they go to a bone setter, all of them put some bandage for 4 weeks. So most of the patients actually come at 4 weeks. So when they come at 4 weeks, you can still try a reduction under digital block, see how much movement is coming. After 6 weeks, it is generally not possible to get a close reduction and you need to do something open, either with prior destruction or directly we can do an open procedure. If there is gross arthritis, we need to straight away go for fusion. However, most of the patients would be in 4 to 6 weeks category, where what we can do is we give a digital block to the patient and then see whether there is any flexion possible under block. So this patient, we can see there is about 20 to 30 degrees of flexion possible. So that means it is not a frank dorsal subluxation or dislocation of the joint. And with traction, we see that there is some amount of joint space which is coming up. Again, a positive thing. So if we are able to reduce, if we are able to get a joint space, that means we can manage this patient by closed means. Next thing to see is when on passive flexion, you are getting a hinging or gliding. So what it means is you do a passive flexion of the PIP joint and look for the glide of the base of the middle phalanx over the head of the proximal phalanx. So if it is hinging, it will hinge over here and there won't be any gliding. If there is gliding, the base of the middle phalanx will go down onto the head. This gliding is a good sign. So if we see this gliding after our traction and manipulation, that means we can manage this patient by closed means. As in this case, we could get a good gliding here, and we put the Suzuki frame for him, which we give a traction, which is of sufficient amount to maintain a joint space. And good thing about it is it allows immediate mobilization of the joint. And this is on table, patient able to do almost 90 degree of flexion at the PIP joint. And this, even if we are able to achieve 90, the patient would be quite happy. However, at times the joint will be very tight and we will not be able to move the PIP joint even under anesthesia. In such cases, especially if there is a lot of swelling in the joint where you don't want to straight away do an open procedure, it is good to put a distractor for such patient. And we kept a distractor for this guy and we distracted for 10 days. The plan was to mobilize with a Suzuki frame after that. However, to our surprise, this patient without the frame itself, with just by distraction itself, we could attain such a good range of movement. And this is his video at 2 months post procedure. It's a perfect result. So when you've done a distraction, you get a good joint space and then you mobilize the patient with digital block and see if with the digital block itself is able to move well, then there is no need to put the frame. Else you can put a Suzuki frame and mobilize them with the frame for another 2 weeks. However, if the patient is coming after 6 weeks, these closed techniques would not work. At that time, the choice is basically between a volar plate arthroplasty or a hemi-hamate arthroplasty. Volar plate arthroplasty is a technique in which the damaged part of the base of the proximal phalanx is replaced by the volar plate interposed in the slot where the cartilage is lost. The hemi-hamate arthroplasty is a newer technique in which the damaged part of the bone is removed from the base of the middle phalanx and it is replaced by a cortico-cartilaginous graft taken from the hamate. Now, how to choose between the two? Both are good. Volar plate arthroplasty is more conventional operation and a lot of people are very comfortable with this. Hemi-hamate is a new operation. It is good, it gives the orthopedic feel, but it is an exacting operation. In case you break the graft, then you are in big trouble. So to objectively decide between the two, The 50% is the cutoff. So if the volar 50% of the base of the middle phalanx is damaged, that means this joint is very unstable. It requires a stronger stabilizer like a hemihamate bone. However, anything less than 50% can be managed by volar plate. Because if volar plate is advanced too much high up, it also gives a fixed flexion deformity and patients will not be very happy. However, with hemihamate, you can get a good range of movement, more than what you can get by volar arthroplasty if the loss is much more. Both are good operations. So this patient who presented late, we can see about 20% of the articular base of the middle phalanx is damaged. So we did a volar plate arthroplasty for him. This procedure is quite simple. You go by a volar approach, retract the flexor tendon on side, shotgun the PIP joint, make a nice slot for the volar plate, interpose the volar plate in between, and tie it with a button on dorsum of the finger. And you can start movement at 2 weeks. Usually one small wire is kept for 2 to 3 weeks, and after removing that wire, we can start movement. So this patient, you can see we got a very good result in this guy, and we cannot even make out which finger is injured unless you see a small swelling over the PIP joint. So it gives good result. However, it is not good for patients who have loss of more than 50% of the articular surface of base of middle phalanx. And in such case, you should go for hemihamate arthroplasty. This is a very innovative operation described by Mr. Hastings. So it takes a dorsal part of the hamate articular surface and it exactly matches to the base of the middle phalanx, and it is fixed with 2 screws in such way. So this damaged part is removed and it is fit with a piece coming from hamate, which exactly resembles the shape of the base of the middle phalanx. One important thing is it should have this volar curve. If the volar curve is absent, again you will have dislocation. So this technique needs perfection. Otherwise, you will not get a good result. It has to be a perfect match. So you can see over here the perfect match for 2 condyles of the head of the proximal phalanx, and we got a good reduction. No subluxation, a perfect curve there, which will give all the stability. If you get this type of good curve, there is no need to even try to suture the volar plate, though we can do that. And once this type of curve is attained, we can mobilize the patient immediately, and you can get a very good result of this kind. You can see this patient at 2 months, almost full flexion and full extension at the PIP joint. And it heals quite nicely. To summarize, PIP joint injuries are not to be missed. We should not consider them as simple injuries. We must take a perfect lateral view in all the cases who present with finger injuries. And if we are able to diagnose them and treat it on time, the treatment is quite simple and the results are very good. However, if we are dealing with late presentations, the patient will not come on time or because of some reason they could not take treatment, these patients also can be managed very effectively. The main thing is to get a mobile and pain-free joint, which can be got in almost all these patients unless they have a gross arthritis. However, nothing is better than managing them early. So don't miss such injuries. Suspect, have a proper lateral view and treat them appropriately. Thank you very much.
Thank you, Praveen sir. Thank you so much for such elaborate talk. Just be for some time because we'll have a question in the end of the session.
Sure.
Thank you, sir. So very good afternoon, friends. I'm going to talk on about some idea, innovation, and recent advances in hand fractures. I'll present a few interesting cases. They might be the eye-opening cases. So he is a 25-year-old gentleman. He's right hand dominant. He's basically the OT technician of GTB hospital. He had injury and he presented to me with the deformity or the PIP joint of the right middle finger. And this was the X-ray. So you can see. Is it my screen is visible?
Yeah, it is visible. Ajeet, we are able to hear also.
Thank you, sir. Because some technical issue has happened. So this patient presented with injury to the middle finger, PIP joint, and you can see that there is a clear-cut volar dislocation of the PIP joint along with the central slip avulsion fracture. So this central slip is attached under the base of the middle phalanx. And if there is a dislocation of the volar dislocation of the PIP joint, the central slip is avulsed, and you can see that there is a big fragment of the bone along with the central slip. So what are the deforming forces? So whenever the central slip avulsion fractures, the lateral band slips volarly, and what will happen that will cause to the extension of the DIP joint, and the patient will land up in the Buthonia deformity. If there's a volar dislocation happens, there's a pull of the FDP tendon over the distal phalanx, and that will lead to the swan neck deformity. So what are the treatment options for this kind of a fractures? It may be conservative treatment, but if there's this kind of dislocation, probably you have to take patient in theater, reduce it, and you have to splint it properly. But for the surgical treatment, there are many options to treat these kind of injuries. One is you can put the suture anchor, you can pin the fragment. If it is a big, you can put small screw also, and you can put the suture fixation. So if fragment is big, it should be fixed with the screw, but we should be always careful about that. If you are putting the screw, there's a possibility of the cracking of the fragment, and you will end up in the big problem. If the fragment is small, you can put a small suture anchor there and repair it. But I did something different. I did the tension band wire for this kind of fractures. So, like we do the tension band wire for the auricular fractures, like that we do the TPW for the patella fractures. Like that, I put a small stainless steel wire for of around 6 millimeter to 7 millimeter kind of that, and reduce the joint, and I pass the tension band wire along and pass through the extensor tendon, and I did the tension band wire for this fragment. So this is the final intraoperative image intensified pictures, and this is after 6 months. The fragment has united very well, and this patient has, this is a kind of outcome. He has a full flexion, full extension. So you can see that the patient has a completely full flexion and full extension. There's another case, there's another patient. So there's another patient. He has a road traffic accident. He has presented to me with this kind of X-ray. As in the previous talk, Dr. Praveen has told that the importance of the lateral view. If this patient was treated conservatively, there's a fracture of the middle phalanx. There's fracture of the middle phalanx, and after seeing this X-ray, the treating consultant told that it can be treated conservatively very well. But when this patient came to me, I did the lateral X-ray. See the kind of lateral view after the patient's where there is completely the middle phalanx is shattered. It is intra-articular comminuted fracture, and it is and unfortunately this was the open injury, and this this boy has came to me. He's a aspirant of the police forces. He has qualified written examination. He came to me. He was a lot of worry because his interview was on the pending, and he has the whole career of his was dependent on this finger. Because he told, sir, if I will not, my finger will be not all right. I will not get my job. I have qualified written, but my interview is pending. So he came to me, and this was intraoperatively photographed. You can see that there is a this is the central, this is the fragment of the middle phalanx base, which is evers along with the central slip. Along with the central slip, you can see that there is an intra-articular defect, there is chondral damage, there is cartilage injury of the proximal phalanx head, and you can see that the combination at the base of the proximal base of the middle phalanx. This is another image. This is the middle phalanx base. This is chondral injury. So how to fix this injury? So open reduction and fixation with the plate or screw? Definitely not, because this is the open injury. If you're going to put the screw in such a comminuted fragment, it is not going to hold, and you will land up in the big problem. As it is open injury, it is not possible to put the plate also. So how to do? Pinning, is the pinning will work, or the patient, we should go for the primary fusion of the PIP joint. So what I did that, minimal fixation. I reduced the fragment, I put a small K-wire from the dorsal to the volar side, I reduced the fragment, I just distracted the joint. And you can see that the intraoperatively image, the joint is very well reduced. And I repaired, after that I repaired the extensor tendon. And this is the result. You can see that the joint is, there was a chondral injury. What I did that I took small sutures and repaired the cartilage over the head of the middle proximal phalanx. And you can see that the X-ray after the 3 months, that the joint is very well congruent, very well reduced. And this is the kind of outcome patient has. Almost full flexion, full extension. And the most best part of this story is that he got the job. He was selected in the sub-inspector. So he was very happy. He came to me. And next, I'm going to talk about this. This is intramedullary fixation of the metacarpal fractures. In 2015, Del Penal has came with this article where there is an intramedullary fixation of the metacarpal fractures. So we have used the intramedullary fixation for the tibia, we use the intramedullary fixation for the femur, we use headless compression screw for the fracture of the scaphoid, for the radial head, for the capitulum, for the capitate. But here the intramedullary fixation, headless compression screw is used to fix the metacarpals, proximal phalanx, middle phalanx. So what are the indications for this kind of a fixation? When the metacarpal fracture, metacarpal neck and shaft fracture is there, when there is a subcapital fracture, and when there is a transverse and the short oblique fracture is there. So what is the absolute contraindication for this kind of fixation is that when there is a child has not attained maturity, or where there is an open epiphysis is there. When you are suspecting any kind of infection to the patient, then ideally the intramedullary fixation should not be used. What are the relative contraindication? When there is a long oblique fracture, or when the partial cortical continuity cannot be reestablished by in bifacial fractures, or when there is a subchondral fracture. In subchondral fracture, it's difficult to put headless compression screw because you will not get the purchase and the distal cortex. So how to do this? This is the dorsal approach for the metacarpal joint. There is a longitudinal incision in between the extensor tendon. Divide the extensor tendon longitudinally. Expose metacarpal head, and you can see that you can expose the metacarpal head, see the head properly, put the guide wire, and then you drill it and put the screw inside. This is another patient where there is a fracture. I took this case from the Dr. Arya from Kolkata. He has done this case. There is a fracture of the fifth metacarpal shaft, and he has put the headless compression screw, and it is finally unite. And this is the outcome patient has. Full flexion and full extension. So what is the advantage of using headless compression screw? It provides stability and strong fixation, so we can early mobilization. It is better with the, in comparison with the K-wire because you can start mobilization early. Because you are putting this implant inside the medial canal, so you are not disturbing the periosteum. There is no possibility that the implant is going to stick with the extensor tendon. So there is no adhesion of the extensor tendon. There is no periosteal injury. So intact periosteum and no extensor adhesion to implant. In case of multiple metacarpal fractures along with the soft tissue defect, where you are suspecting that sometimes many times it happens that the patient has a dorsal defect and you have put the skin graft over there, or the soft tissue condition over the dorsum of the hand is not good, where you cannot put any plate or the screw. So in that scenario, you can put these kind of implant in the middle canal. There's another recent technique. What we can say that there's a, as Praveen sir has proved, that there's a PIP joint fracture dislocation that you can put the Suzuki fixators. Or this volar plating you can do in case of even the chronic cases also, where you can go on the volar side, reduce it, and you can put the plate on the volar side. This is the hook plate which is not available in India, but there are some other plates which is available in India, and we are using, that is the T plates. These T plates can also be used for the volar fixation, and it gives a very strong fixation on the volar side. You can reduce the joint and you can start mobilization early. So I want to summarize that identification of the key fragment is important. Minimal fixation with distraction, especially when there is a severe comminuted fracture is there and open injury is there. Thorough debridement of the soft tissue and repair of the tendons are important. Intramedullary fixation, especially in multiple metacarpal fracture, is useful. Thank you. Thank you so much.
Thank you, Dr. Ajeet, for wonderful lecture on small joint session, and see the difference what we have been doing and what you have been doing with better results. Now the papers are open for questions. Is there any questions, please? Dr. Ajeet is here, and Dr. Praveen also is online.
So I have a question for the Vikas Gupta sir. Vikas Gupta sir, are you there?
Hey.
Yeah. So Vikas sir, do you do wrist arthroscopy in all your intra-articular fractures? Where do you and what are your indication of the TFCC repair, fresh TFCC repair in case of distal radius fracture?
So TFCC repair after fixation of distal radius. See, I'm not doing an arthroscopy in all the cases which are complex, or cases, bilateral cases where scapholinate is already seen, or TFC DRG is very unstable. So first we fix the distal radius fracture, then you check for the stability. If you're getting a stability in full supination, you're getting a stability, then you can treat them with the above elbow slab. If that is unstable even after full supination or full pronation, that means the ligamentous injury is there, and in such cases either you pass a K-wire through the just proximal to DRUJ, radial K-wire, or we do the TFCC repair. So it is not that all cases of DRUJ instability you should do the TFCC repair.
Thank you, sir. Praveen sir, one question for you.
Yeah.
Yes, sir. Please.
A question to Dr. Bhardwaj.
Yes, sir.
Very nice, elaborative lecture, sir. So how much to distract and how long to distract? The case you showed, which was a delayed presentation, that worked only with distraction. So when you are distracting it, how much millimeter has to be left distracted and how long?
Yes, sir. So when we are distracting the PIP joint, sir, so in acute setting, suppose you are putting a frame, we should only distract as much as you joint space of the adjoining finger. But when you are doing for chronic case and you are planning to do an open reduction, we should very repeatedly keep taking X-rays every third day. The gap should not become double than the size of the adjoining joint. Because in finger, there is a big risk that if the ligament are totally injured and you are distracting, it may become too big. It got too distracted and it can result in some avascularity of the finger. So we need to be very careful. The distraction would never go more than 6 to 8 millimeters if I have to tell a number.
Daily distraction, how much?
Yeah, half. Yes, sir. So 0.5 millimeter per day, 1/4 in morning, 1/4 in the evening. So if you do for 10 days, then you would get somewhere around 6 millimeter of distraction.
Thank you, sir.
Thank you, sir.
Thank you, sir. So, Praveen, sir, one question for the benefit of audience that what are the upper limit of putting the Suzuki fixator? One. Second question is that is it necessary that a joint should be reduced before putting the Suzuki fixator?
Yeah. So I think second, I will answer first. So the first prerequisite is that joint should get reduced for putting a Suzuki fixator. So the first question answer also lies there. If we are able to reduce the joint, then you can put the Suzuki fixator. And usually it will be possible till maximum of 6 weeks. After 6 weeks, the reduction will not be possible. Then we will have to do open.
Is it possible that we should do the open reduction and then put Suzuki fixator?
Yeah.
What about this?
Yeah. So it is possible, but many times if you have done an open reduction, you would require to release the collateral ligaments. And once you have released the collateral ligament, you are a little bit worried about doing too much of distraction. So it is possible, but we need to be very careful and to make sure that you are not over distracting the joint. Because recently one of our friend, Dr. Parag, he published a case of avascularity of the finger after Suzuki frame. So it is very much possible.
Okay, thank you, sir. Thank you, Praveen, sir. Thank you, Vikas, sir. Thank you so much for explaining.
Ajeet, your results were very nice. So when did you start mobilizing those? They're very stunning results, both of them.
Yeah, so I recently keep immobilized for the 1 month because I have put intra-articular wire. So I have immobilized for the 1 month, and after that 1 month I removed the wire and started mobilization.
Very nice result.
Thank you. Thank you so much, sir. Thank you.
Thank you, Dr. Ajeet, also. Thank you, Dr. Praveen, and thank you, Dr. Vikas, for a nice discussion and lecture.
Now we'll start our next session, spine session.
So we will now start our next session, which is on spine and infections. And first, I would like to invite the panelists for this session, chairperson for this session, Dr. Rajiv Agarwal, sir, Dr. Prajnesh, and Dr. Vipul Agarwal. Dr. Vipul Agarwal. So we would have 2 lectures in this session, and both the speakers will join us online. The first talk is on approach to thoracolumbar fractures, current concepts, and this talk will be delivered by Dr. Ajoy Shetty from Coimbatore.
Good afternoon. Can I start my talk?
Yes, sir, sure.
Yeah. Good afternoon. It gives me great pleasure to be there along with you online for this meeting of UP Trauma Association. My sincere thanks to Dr. Lamba and Dr. Harpreet for giving me this opportunity. My talk would be on approach to thoracolumbar fractures. What are the current concepts? Thoracolumbar fracture, as you are well aware, are fractures of the thoracolumbar region, that is between T10 to L2. Is the most common site of fracture in the spine. and results in significant disability, deformity, and neurological deficits. The goals of early trauma care is to identify them early, protect against further injury, and to optimize conditions for maximum recovery. What does it mean is that when you see a patient with the trauma, I mean, you have to be extremely careful not to fall for the obvious, and in a patient with a spine fracture, not to miss associated injuries. Vice versa, a patient with an extremity injuries, not to miss a fine fractures. As you can see in this particular patient with a D12 flexion distraction injury, when you look at the X-rays, the X-ray looks like an innocuous fracture of the thoracolumbar junction. But when you look at the X-rays of the chest carefully, you can see that there is a diaphragmatic rupture, which is well seen in the CT scan, and the gastrothorax, the stomach has moved into the thoracic cavity. And this needed a surgical intervention, which can be done by laparoscopically too, to reduce it and repair the diaphragmatic hernia. Therefore, whenever it's possible, whenever it's availability, and depending on the situation, if the patient is polytraumatized, it's always important to get a whole body CT scan, because the advantage of whole body CT scan lies in the fact you can complete the whole overall procedure within 2 to 3 minutes. You can scan from the head up to the pelvis, and including visualization of the chest and abdomen. And we would always advocate a whole body CT scan in a patient with a polytrauma scenario. What about getting an MRI done? MRI takes time. Therefore, it has to be done only in a stable patient. You, in an emergency scenario, when the patient has got a high hemodynamic instability, a whole body CT or a CT would be a better option rather than getting an MRI scan done. Therefore, when the patient is stable, it's important that you need to have a whole cervical spine. If you are taking a region of thoracolumbar, be sure that the center takes a whole spine screening, because it helps us to identify the lesions at other level, which may be significant and which may warrant a surgical intervention. Therefore, it's always mandatory that whenever you choose an imaging, plain radiographs forms the first line of treatment, CT scan forms the second line of investigation. MRI should be done only in patients who are stable, in patients who has got a neurological deficit, especially when there is a progressive neurological worsening, or when the neurological level do not correspond to the level of injury what you are seeing. It's also important in patients with posterior ligamentous complex injury and in burst fractures. The other important goal, any patient with a trauma, is to prevent a secondary injury. As you can see in this example, this patient had a stiff spine with the fracture of the thoracolumbar junction, and he moved from one center to the second center, and by the time he came to us, the fracture had grossly displaced, and he went from a state of being a normal neurology to a state of being a completely paraplegic. Therefore, our primary aim whenever you diagnose a patient with trauma is to prevent a secondary injury, either by using a Philadelphia collar depending on the level of injury, or by using spine board. Be careful when you are transferring the patient. Always use log rolling methods when you are examining the patient. The precautions should be there all the time. The next important aspect with regards to a thoracolumbar injury is to evaluate the neurological level and the completeness of the injury. It's important to differentiate between complete and incomplete injury, because complete injury, the chance of neurological recovery is relatively very, very less. Whereas in incomplete injury, even if it's a Asia B, that is, there is a sensory function only is preserved, there is a 40 to 50% of the chance that a significant percentage of them will improve from grade B to grade C or grade D. Therefore, it's important for us to determine whether the injury is complete or incomplete. At first, we have to rule out the patient is come out of the spine shock by looking at the bulbocutaneous reflex. Always look for sacral sparing. In a patient with a presumed complete spinal cord injury, always look for sacral sparing. The sacral roots, in the cord, the sacral tracts are arranged in the periphery. Therefore, the sacral roots can be preserved. Therefore, the presence of a perianal sensation, voluntary anal contraction, a toe flexion might imply that the patient has got an incomplete injury. And this also implies that the chance of neurological recovery is comparatively much better. The most important aspect of early trauma care is to optimize the conditions for maximum recovery. Now, basically, you know that the injury mechanism of the spinal cord could be a primary injury, that is at the time of accident, which cannot be treated. It's only can be prevented by having safe measures of road traffic, preventing road traffic accident or fall from a height. But what matters is to whether we can prevent the secondary cascade which follows the primary injury. We do know now for sure that steroid does not have any role, and we do not advocate or support the use of high-dose steroids in the management of spinal cord injured patients. Stem cells definitely is not proven and should not be advocated at this present state. What really matters is the fact that to prevent hypotension, number one, the spinal cord as such, like the brain, it cannot auto-regulate. Therefore, the perfusion of the spinal cord depends upon the systolic blood pressure. Therefore, any drop in the blood pressure will lead to an irreversible spinal cord injury. Therefore, it's important that you have to maintain the MAP greater than 85 millimeters of mercury, prevent hypoxia, hypotension, hypothermia, and electrolyte imbalance. Coming next to the other concept is the concept of column. We do know about the 2-column concept and also about the Dennis 3-column concept. What is now accepted, we have moved back to the 2-column concept. That is, we have the anterior column, which is the most commonly injured column, that is the vertebral body and the disc, and the posterior column, that is the posterior elements, the lamina, pedicle, and the facet joints. And these, if it's a bony column, if both the columns are injured, the injury becomes unstable. If it's a bony column, you can see that in the radiographs or in the CT scan. But we have to remember the posterior column not only has got a bony element, it also has got a ligamentous element, what is called the posterior ligamentous complex. The posterior ligamentous complex also contributes to the stability and resists the anterior forces that exist due to gravity. The posterior ligamentous complex includes supraspinous and interspinous ligaments, the ligamentum flavum, and the facet capsules. Then how do you identify whether this is injured? And this injury is very, very important for us to identify in a patient with a burst fracture. Therefore, whenever there is a patient who has got a burst fracture element in the front, we should always look for whether the patient has got a PLC injury. But unfortunately, the posterior ligamentous complex being ligamentous is very difficult to visualize on X-rays or CT scan. And even in the MRI, unless you get a situation where you can see a clear cut like this, it could be indeterminate. It's difficult to visualize even in the MRI. Therefore, how do you identify? It could be direct evidence. There could be interspinous widening when you are examining the patient. But most of the time, you imply by indirect evidence by looking at the CT scan or the radiographs. Whenever there is a canal compression of greater than 50%, greater than 20% angular deformity, greater than 50% compromise, that implies the posterior ligamentous complex is injured and implies that the burst fracture is not a stable burst, it's an unstable burst. Therefore, based on the 2-column concept and 3-column concept, we have an evolution of classification system. Initially, we have the plain radiographic based classification, and later, now we have the CT and MRI based classification, which have moved from the McAfee, which we all know and use during our student days, and we still use it. And now the latest one is the AO spine thoracolumbar fracture classification. The advantage of AO spine thoracolumbar classification system is that it has got 3 components to it. It has got the neurology, it has got the modifiers, and also it has got a morphological, that is the mechanistic type of classification based on the mechanism of injury, the compression, distraction, and the translation injury. As you can see, it moves from severity from the compression injuries to the translation injuries. And this is also important. In the subgrade also, it moves from severity from A1 to A4. Therefore, these are relatively stable injuries, the A type, whereas the B type and the C types are relatively unstable injuries. Therefore, it's easy for us to understand when somebody tells us that he's got an A3 injury, we know that it's a relatively, probably a stable burst fractures. And then if it's a neurologically intact, we might give an option of conservative treatment. Therefore, once you have classified these particular patients, the next important thing that comes to your mind is whom to conserve and whom you need to operate. Therefore, the treatment depends upon the morphology of the fracture. The AO classification helps in that. Neurological deficit, again, the AO classification helps in that, and the general condition of the patient. In the presence of polytrauma, sometimes even a stable fracture, we may prefer to fix it because with the idea of mobilizing the patient earlier. Apart from that, the two major conditions which determines are the morphology and the neurological deficit. We should have a thorough clinical and radiological evaluation before we come to that decision. Therefore, the factors we need to consider are neurology, the stability of the fracture, and various variables. If you look at the neurology, in complete and incomplete spinal cord injured patients, we always prefer to operate. Why? It helps us to realign, it helps us to give stability, it helps us to mobilize the patient and give a better chance of recovery. Whereas in the patient who is neurologically intact, we have to look at the fact whether the injury is stable or unstable. For us, it's easy to understand, as I mentioned earlier, you look at it as a two-column. And if you've got a bony injury, both from the front and back, it becomes a relatively unstable injury. Or if you have a bony injury in the first and front and the posterior ligamentous complex injury in the back, it also gives us an idea that both the column is affected and then it becomes an unstable injury. As I mentioned earlier, the thoracolumbar injury of AO gives us a better idea about defining based increase in severity from A0 to the C type. But here an example is a bony chance. The bony chance fracture need not be unstable. Even though both the columns are injured through the bone, it could be stable if the kyphosis angle is less than 19 degrees. As in this case of ours, a bony chance fracture, there is no significant increase in kyphosis, treated conservatively with the eventual good outcome. But the issue comes in a burst fractures. You have to look for the presence of posterior ligamentous complex injury. And as I mentioned earlier, whenever you find the compression is greater than 50%, okay, the kyphosis angle is greater than 20 degrees, there is a canal compromise which is greater than 50%, that's an unstable injury. And usually CT scans and MRI might give us a clue, but sometimes it is not always straightforward. Then what we can do is we can treat the patient conservatively, reassess him after a few days or a week's time, take one more standing radiographs. If the difference between the standing and lying radiograph is about 10 degrees, that means to say that probably the PLC is injured and the injury is unstable, you might have to change your decision plan. Therefore, based on the morphology, most of the A1, A2 fractures or the compression fractures can be treated conservatively. Bony chance fractures can also be treated conservatively if there is no significant gap at the fractured elements. Whereas the ligamentous chance, hyperextension injury, and the fracture dislocations, that is the B2, B3, and the AO type C, they have to be operated. The issue you have to take into gray zone is the burst fractures. You have to be 100% certain in a neurologically intact burst fracture that the PLC is not injured for you to make a decision of conservative treatment. As shown by Wood et al., they had this group of patients, which they first published in 2003. They followed the same group of patients and published in 2015 for a duration of more than 16 years and found that the stable burst fractures patients who were treated conservatively had a better results than patients who were surgically treated. Therefore, we have to understand, and the most important thing, you see a patient of ours in 2002, there was a significant retropulsion, normal neurology patient. He was treated conservatively, and you see at 2013 how the canal has remodeled. The nature has got a great ability to heal and remodel. Therefore, unless the patient, the injury is unstable, unless the patient has got a neurological...
Excuse me, please. Sir, we are running short of time.
Okay, I'll be finishing. The goal of the non-operative treatment is to achieve that the spine is stable, the PLC, and you can treat them conservatively by bed rest, brace, molded orthosis, or hyperextension cast. Our protocol is to treat with brace. Non-operative treatment is the key. You take serial radiographs. The only advantage of surgery is that the patient can be mobilized much more faster. To conclude, do not miss an injury, prevent secondary injuries, optimize the recovery, and the treatment depends upon the pathomorphology of the fracture, neurological deficit, the condition of health, and the presence or absence of polytrauma. Thank you very much.
Thank you, sir, for a very nice presentation. Now, I would like to invite Dr. Ankur from ISIC for his talk on current trends in the surgical management of thoracolumbar fractures.
Thank you for the kind invite. Can I share my slides?
So the duration of talk is of 15 minutes.
Yes. Good afternoon, everybody. Good afternoon on Sunday afternoon, and thank you all for joining this session. And I would like to thank the organizers, the Kanpur Orthopaedic Association, for having me here as a speaker. It's always a challenging task to speak after Dr. Ajoy, and but then he makes our work easier as well. He has gone through in very much detail about the concepts of a thoracolumbar fracture and how these need to be treated. So what I'm going to talk about is basically the surgical aspect of the management of these thoracolumbar burst fractures and the thoracolumbar injuries. And we'll be straight away diving into, the big questions which are asked when you are dealing with these injuries. And probably this is what we are going to cover in this talk. What we are going to talk about is, whether a surgical or a conservative management should be done for a patient with intact neurology. What is a stable fracture? What is a stable burst? What is unstable burst? How do I decide it in a patient? I know the theory, but how do I decide it in a patient? What approach should I take? Should I take an anterior approach or a posterior approach, or a combined anterior and posterior? Is there any relevance of the Gaines classification now? Should I be calculating these scores? And how many levels should I fix? Should I get into the fractured vertebra or not? Should I do fusion or not? So we'll be looking at all these questions which crop into our mind during our clinical practice and see if it gives us some clarification. So we'll start away with a case. A male 25 years of age presented with a road traffic accident around 12 hours back with intact neurology. And this is how his sagittal MRIs look like. It's a stir image. And you can see that there is a L1 burst fracture with some compression on the cord there, but the patient is intact neurologically. This is how his x-rays look like. And you can see that there is an involvement of the anterior as well as the middle column. So it's a burst fracture. What would you think? So patient's neurology is normal. Patient has a burst fracture. Should we operate this patient? Should we conserve this patient? Or would you like to assess the stability of this fracture? And if so, why? How do we assess? We know that dynamic X-rays can help us in assessing the stability of a fracture. But at the same time, in the scenario where there is a fresh fracture, should we be going ahead and doing a dynamic X-ray or not? What are the indications for dynamic X-ray? So let's look at them. So as Dr. Ajoy pointed out in his talk, PLC's disruption is something which is very important to understand whether a fracture is stable or unstable. And if there is a PLC disruption, then the fracture is unstable. And probably these are the ones which probably we would like to be sort of going ahead and doing surgery. Now, MRIs are something which are able to detect these posterior ligamentous complex injuries in majority of the cases, in a lot of cases, but in a lot of cases, they are not able to, clearly delineate whether there is a posterior ligamentous complex injury or not. So certain features on an X-ray can help us understand that. So as Dr. Ajoy have pointed out, if there is a loss of height of more than 50%, if there is an angle in the fractured vertebra of more than 30 degrees, or if there is an interspinous widening, then these are the scenarios where you would think that there is an instability. At the same time, at the same time, we have to understand that there are still no clear-cut criteria for instability in a thoracolumbar burst fracture. But let's say if you see a patient who seems to be fitting into these stability criteria, then probably these are the patients you would like to really reconfirm with a dynamic X-ray if they're really stable, and whether you would like to go ahead and do any surgery for them or not. But the ones which are presenting with an instability criteria, where you can already see that there is a PLC injury, or where you can see there is an interspinous widening, or if the angulation of the fractured vertebra is more than 30 degrees, probably these are the ones who don't need a dynamic X-ray. So you can consider, like in our case here, so we had done a dynamic X-ray here, and we thought that the fracture was quite stable. There was not major compression which was happening. The patient was neurologically intact. And so we decided to sort of hang on and take our chances and treat this patient conservatively. So this is what we have been looking at: surgery versus conservative in burst fractures with normal neurology. So if we go into the literature, there's a lot of literature on this. There are very high quality RCTs which are available, and the second one by Wood et al. In 2003 and then 2015, which Dr. Ajoy talked about, they showed that with surgery versus conservative, you can get similar functional outcomes or probably even better in the long term in the conservatively treated patients with normal neurology. And only the third RCT, it talked about, probably surgery may be better for complete birth fractures in some cases because of less post-traumatic deformity. But more or less, these fractures with normal neurology can be treated conservatively. And a high level of evidence exists for the same in the form of, RCTs, in the form of systematic reviews. And this is something which has become more or less very acceptable all around the world. However, when we go on to from stable burst fractures to unstable burst fractures, they also have been managed conservatively. And this was a landmark paper by Chow et al. In 1996, wherein they found that even they had treated patients with PLC injury, and these patients did not have inferior results. And the authors concluded that they did not believe that the ligamentous injury of the posterior column is a complete contraindication to non-operative management. So probably, there is always a gray zone which exists in these fractures, and we have to take our decisions very carefully. Again, another paper. Now, this paper was by Dai et al., and they talked about unstable burst fractures. Even with neurological deficits, some of them had, and they were treated conservatively. And they also came up with a interesting conclusion that the load sharing classification could be used not only for guiding your surgical approach, but also for deciding which ones you want to operate, whether you want to operate or not. So let's say if you have a scenario where there is a burst fracture which is quite communicated, but the patient's neurology is normal, you don't see a PLC injury, and you want to take a call whether you would like to conserve or whether you would like to operate. So in that scenario, a load sharing classification may help you in deciding whether you want to operate or not. And probably what they suggested in this paper was that if the LSS score is less than 6, then probably these patients can be treated conservatively. Just to demonstrate what we've been talking about, another case, 17-year-old male, he had a fall from height around 48 hours back and had paraplegia with AIS-A neurology. And this is how his X-rays looked like. And you can see that there is a significant angulation at the thoracolumbar junction with a burst fracture. And this is how his CT scan looked like with almost complete canal compromise. This is how the MRIs look like, and you can see that the retropulsed posterior fragment is completely pressing the conus and the cord area. So what would be our approach here? Would we go and do an anterior decompression and fixation? Would you like to do a posterior, or would you like to do a 360-degree correction? So the question is, why are we talking about anterior approaches? We know that anterior approaches are able to provide a good anterior support, especially in the scenarios where there has been a very comminuted fracture, and you can then through an anterior approach put a large strut graft or a wide cage. But at the same time, the neurology is also, if there is there, then usually in these patients it is the anterior cord syndrome which is usually the neurological syndrome, and probably it can be treated more in a more effective way anteriorly. However, there have been many studies and many meta-analysis where they have found that there is no significant difference between the anterior and posterior approaches in the clinical, radiological, and functional outcome. And the anterior approaches may be fraught with more complications. There may be longer operative duration, increased blood loss, and increased injury to the major vessels. So this is another CNS guidelines from the Congress of Neurological Surgeons, who looked at high level RCTs and 6 retrospective studies, and they also concluded that the approach probably does not change the clinical outcomes. The problem with anterior approaches is it can lead to more complication rates, increased blood loss, pulmonary complications, vascular injuries, femoral nerve injury, sympathetic plexus injury, and injury to the visceral organs. So that is why the world has slowly moved from anterior surgeries to posterior surgeries, and wherever the anterior reconstruction is required, it is done through the posterior approach itself, and that's what is called as so this study had described quite nicely how it can be done, this is a 3-column reconstruction by single posterior approach, and they found it to be safe and effective along with other advantages which you have this approach. So what we did in this case was similar to that. what we have done is a posterior fixation along with decompression and anterior column reconstruction with an anterior interbody cage and grafting in the fractured, just above the fractured vertebra, between the superior end plate of the fractured vertebra and the supranormal vertebra. So this is what we could reconstruct the anterior column and at the same time do the fixation. But you must understand the next issue is how long should our constructs be? Should it be short segment fixation or it should be a long segment fixation? And what is the role of index screw or the fracture screw? So we know that the long segment fixations are basically able to give a 3-point fixation, and they are able to sort of control the superior and the inferior part of the fracture better. But at the same time, the short segments are usually used when you want to attain stability, either by cantilever bending or if you have an anterior column integrity already there to support that. So this is how the short segment would work. Why short segment is better? Because it helps in saving levels, and the more levels you save, the better will be your movement of the spine in lumbar spine for flexion and extension. And also, as the fusion levels will increase, the mobility of the spine gets affected. So that is why short segment fixations are usually better bargains. But at the same time, the problem with them is that the short segment fixations are more prone to failures, and probably that's why long segment posterior fixations have stood the test of the time, and a lot of surgeries have been done with long segment fixation. However, in this controversy, there is a lot of controversy which goes on between them. There's a lot of literature which says that the short segment fixation has a very high failure rate, whereas there are some meta-analysis and review articles which say that there is not much difference between the short and the long segment. The controversy continues, but in the meantime, there were some few more studies which were done, and this was done on the concept of the intermediate screws or the fracture segment fixation, where people started trying to put the screws in the fractured vertebra itself, and then spanning the construct one above and one below. And what they found is, both in biomechanical studies and in clinical studies, that if you put a screw in the fractured vertebra and fix the fractured vertebra along with one above and one below, then they are able to give equal amount of strength to the construct then as compared to a long segment or as compared to a short segment fixation with anterior reconstruction. So this is something which is now gaining a lot of popularity, and this is a review article which was published as recently as 2020, and they looked at 21 RCTs which compared short segment versus short segment and fracture level screw, and they found that the fracture segment fixation constructs are way superior to short segment fixations and equal to long segment fixations or with anterior reconstructions with cage. So this is just one of those cases to demonstrate. So this is a case where there was a L2 fracture along with an AISC neurology, and you can see that we have done a short fixation with a fracture segment fixation, and the patient has gone on to do well. But I must say here that this fixation which we are talking about is relevant to the burst fractures. But when you have a situation like this, where there is a complete dislocation of the vertebra and it's a type C injury, probably a long segment fixation will stand the test of the time. Or if you have a very bad injury, something like this is a young gentleman who had a tractor trawler injury, and his whole trunk was cut into two, and all the visceral organs could be visible from behind with complete dislocations. Now, these injuries are really, really unstable injuries. These are very challenging cases to do with a lot of infection chances. And probably what we have done here is, done a 360-degree type of fusion, wherein we got a long segment fixation along with an anterior reconstruction with antibiotic beads. And this is what we could get at the end of the surgery. So these are the injuries, type C injuries, which require long segment, and they cannot be managed by short segment fixations. Just coming on to my last slides. So is load sharing classification still relevant? There is now a lot of data which says that the load sharing classification may not be relevant as of now, because there is a lot of studies which have come up that the short segment fixations along with index screws may not cause failures to these thoracolumbar fractures. At the same time, there is a talk about whether we need to fuse all these fractures when we operate. And this meta-analysis of 5 RCTs and 3 level 3 studies showed that posterior fixation alone could achieve similar clinical and radiological results as compared to with fusion, and probably fusion is not necessary in the case of thoracolumbar burst fractures. Again, role of MIS is there, and probably MIS is something which you can do more appropriate for less severe injuries with intact neurology and can give you similar result to open surgeries. So the take home message is, if you look at the controversies which we had discussed, the first controversy, whether surgical versus conservative management in patients with intact neurology, these patients can be treated conservatively. There is ample level one evidence on that. Defining instability and assessing PLC and stability is something still which doesn't have clarity, and there is a level 2 or level 3 evidence on that regarding whether a fracture is stable or unstable. However, if we look at fracture segment fixation and the levels of fixation, it is clear from the studies that we need to keep as short segment as possible, and an index screw is very helpful in getting good clinical outcomes. At the same time, fusion is not something which is necessary in all these thoracolumbar burst fractures, and non-fusion can be attempted in these cases. With this, I end my talk. Thank you so much.
Thank you, Dr. Ankur, for a very nice presentation. With this, we conclude this session on spine and infections. We are running short of time, so we cannot take any questions at this moment. Now, we will move ahead to our next session on hip. I would like to invite Dr. Rohit Nath to conduct this session.
Now the spine session is over, and we will proceed to our next session, the hip session. And for the hip session, I would like to invite chairpersons Dr. K.D. Tripathi, Dr. Pankaj Tandon, and Dr. Saurabh Chawla. And the first lecture is by Dr. Mukesh Jain, sir, from Madhya on fracture neck FNS in fracture neck femur.
Just a moment. I'm sorry because there was another lecture in between. Just a minute.
Yes, sir, you can share your screen.
So I'm sorry for the delay. Okay, the topic is FNS. I think this is a new topic in the sense that the experience is not too much. My purpose is not to promote FNS. My purpose is to just show you my experience, what I have done in last 1 year. We have done almost 35 cases in last 1 year. And you won't believe that out of 35, 30 have already united within the span of 2 months' time. So coming to the femoral neck fracture, first we would like to know about what is the clinical problem and what is its solution. And then I will give you a little bit about FNS description and surgical techniques. And after that, I will just give you 1 or 2 cases for a case presentation. Now, if you take the algorithm, fracture neck femur for me, my simple algorithm, anybody who is around 50 years, below 50, in Powell 1, I will go for 3 screws straight away. If it is a Powell 2, 3, then I will go for DHS with anti-rotation screw. If the patient is between 50 to 65, this is a little dilemma here. If patient is not having any comorbidity, then I'm going to fix it. If he is having any comorbidity, then my choice will remain THR. And any patient above 65 and above, either he will go for a THR or bipolar, again, depending upon the physiology of the patient. So the clinical problem is a fracture shear. And what happening is that here the body weight, which is pulling the head down, and the abductors are pulling up. So there is a shearing force always, and ultimately that leads to varus and shortening, and that is the reason for the poor functioning. Now, if you take Powell 1, These are the simple fractures comparatively because the angle is less than 30 degrees. So these fractures, if you fix with a central screw, now what will happen? That this screw cannot tolerate the varus and you will have a varus collapse. But if you put the same screw in a definitive position, which is totally inferiorly in the AP view and in the center of the lateral view, then they can check the varus. But to check the retroversion, you need another screw, which is just parallel to the inferior cortex into the lateral view, and it is centered into the AP view. So the position of a screw is very important in Powell 1. But if you have high shearing forces, like Powell 2 and Powell 3, if you put the same screw on the inferior cortex, it is not going to tolerate. It cannot resist the shearing forces. It means the screw which was helping us in Powell 1 is not going to help us in Powell 2 and Powell 3. Now here is an example. The 45 years female, fracture neck femur. It is Powell 3. And if you go for a 3-screw fixation in this Powell 3, what is going to happen? Even within 2 weeks, the patient had a collapse and ultimately it went to a non-union. Now, the same fracture, again Powell 3, 50 years of female. If you do an angular stable implant and with a derotation screw, I think that makes a sense because this is give you complete stability to check your varus, to check your shearing forces. So to conclude, 3 screws are good for Powell 1 only. And if they are placed in a described position, that is important. And DHS and ARS, they are ideal for Powell 2 and Powell 3. So we are clear about it that Powell 1 needs 3 screws in the right position, Powell 2 and Powell 3, they need an angular stable implant. But why do we want a new approach? Because our routine implants are missing the target. We have seen in the past a lot of non-unions, a lot of failures, a lot of collapse, a lot of shortenings. So we need something more. What we are missing? This is the article 2008 JBJS. The 3 screws, they are not good at resisting shearing in the varus forces, but they are good at compression, but poor to control the shortening. So we cannot go for this. Now there is a novel study in 2005 to 2017. They have treated almost 111,000 patients. And what they found that there was a 33% failure within 3 years after internal fixation. There is another study. In spite of the union, the 60% patients are not happy. Either they have pain or they have a limp or they have a shortening. So overall, presentation with the DHS and the 3 screws, definitely we are lacking somewhere because there are a lot of complications. With the sliding hip screw, you cannot check the shortening. You can prevent the varus, but the shortening may happen. There might be a collapse and ultimately you may lead a shortening. Another less talk problem. This is the most important problem about DHS. When you insert your DHS, there are possibilities, especially in the younger bone and the hard bone, that you end up with a malreduction. And ultimately what happens when there is a malreduction and you try to correct it, there is a spinning of the head. And what happens? There is stretching of the capsule, there is a stretching of vessels, and that ultimately will end up with the AVN. And this is the study Lancet 2017. The DHS has higher rates of AVN than cannulated screw. And the hypothesis is because there is a femoral head rotation during insertion, so there are chances of malreduction and there are chances of vessels to be stretched, and that leads to ultimately AVN. Another important point is that it's a large surgical footprint about DHS. Then there you can have a lateral protrusion of the thigh pain. Then you cannot maintain the tag. And there is no connection between anti-rotation screw and angular stable implant. That you don't know. There is no definitive progress. At times you may have a good reduction and a good fixation, but ultimately you may land up with a non-union. And it is difficult to insert in a small femoral leg with anti-rotation screw because the neck is small. You cannot put 2 implants in one small neck. So what is wrong with DHS? The 2 implants, they don't link each other. They behave differently. In a smaller neck, it is difficult to put 2 implants. We don't know how much will be the collapse. and head spinning rotational forces during insertion of DHS screw that leads to maladduction, and ultimately vessels are stretched, leading to AVN. I think these are the problems with the DHS. So what is the solution and what is the dilemma? The solution is either you go for an open reduction, you fix with the DHS screw, you fix with the anti-rotation screw, and replace your anti-rotation screw with a lax screw, which is a fully threaded screw. It means you made it a length stable implant. That is one solution. And the results of this solution, there are a high union rate with minimum shortening. But there are cases, however, this method of replacing with a full threaded screw, making a stable implant, length stable implant, this method fixation has not entirely eliminated the problem. Still we have delayed unions, still we have non-unions. So fact is this, that these fractures, even in spite of a length stable implant, they need some compression. They need some controlled collapse to heal. So this is necessary. So that putting a long screw, putting a fully threaded screw is not the solution. So what is the solution? The solution is we need an angular stable implant which can prevent varus and shear, which can prevent rotation during implant insertion, and which we can prevent the shortening but allows some compression. It means these fractures, they allow a little bit of compression, which should be a static, and you should have a little bit of compression so that the fracture unites. So now Carl Stoffel, who discovered this femoral neck system, he presented it in 2017, and in last 3 years, a lot of countries has adopted this FNS, but in our country it is available only for last 1 year, and for last 1 year we have done around 35 cases. So what is FNS? The FNS is an easy surgical technique. It has a small surgical footprint. There is no lateral protrusion, no thigh pain. Central position of the neck screw with the ARS is good for Asian patients because this is a single implant together. And then there is a connection between bolt and ARS. So the impaction and the collapse is a controlled collapse. That is the beauty of this implant. And there is a no rotational torque while putting the bolt. It is a very smooth bolt which just slides into the canal. Now, the FNS is available, this plate, which is a left and right for both sides. It has a 130-degree barrel angle with 5 millimeter locking screws. They're available with variable CCD angle, which is same plate can work for 125 to 135. So you have not to have another inventory for it. It provides a wonderful angular stability. And there are two sizes, the 1 hole and the 2 holes. The 2 holes are not available in India. The bolt size are available from 75 to 130. It is the main load carrier, and the bolt has a blunt tip, so there is no reason for a protrusion or damage to the cartilage of the head. Then the locking screw is a 5 millimeter screw, which provides you angular stability. And then there is a anti-rotation screw, which provides you rotational stability. It is in a diverging design, and it goes through the same channel. So there are two implants in the same channel working together, and it allows implant placement even in a small femoral neck. The instrumentation is very easy. It has an instrument insertion handle, one handle, which is a single piece, and then you have two inserts, one for the locking screw for the shaft, another for the derotation screw, and there is a protective sleeve. The features and benefits of FNS, it is designed to provide both rotational and angular stability in one implant. So it reduces the reoperations. FN is 3 times stronger than DHS, and then 3 cannulated screws, and it is equal to DHS. So this is very important that if you compare the cannulated screws, it is 3 times stronger, but it is same from varus collapse, it is equal to DHS, but it enhances your stability rotational. Comparative to DHS, it is 40% better, and it is 150% better to 3 cannulated screws if you just compare them. It's a streamlined procedure, compact design. You have a single central guide and a single insertion handle, so very easy to do. Here is a 40 years male, power 3, garden 4. If you just see that there is a varus and there is a retroversion, and there is a combination also. So what you need is you just reduce it. After reducing, you put your reduction in a guide wire, which is a central guide wire, and then you just ream over this guide wire, and then just you put your bolt insertion, because once you have reamed it, then there is a smooth channel, and just you slide it. After that, you put your locking screw into the shaft. Then you drill for ARS. It is the same equipment, same implants, same instrument. You go through that, and then you put your anti-rotation screw. This is immediate post-op. This is after 5 months, fracture united. There is no collapse. The offset is absolutely normal. Another case, 36-year-old male, came with a complaint of pain in hip. It's a power 3 and a garden 4. Again, in the same way, central guide wire, put your plate, FLS fixation, and then it has a mechanism of compression also. At times, if you're not able to have any distraction, probably you can compress it also. And this is the final poster picture of the hip. And this is after 2 months, fracture united. There is no varus, there is minimum collapse, the offset is almost normal. This is followed after 3 months, fracture fully united. There is no varus, there is no collapse, offset is normal. You can see that after 3 months, the patient is almost walking normally without any kind of support. Another patient, 30-year-old female, came with history of fall 3 days back, all 3, garden 4. Again, we treated with the FNS. This is after 1 month, little collapse, offset maintained. Post-op after 3 months, almost normal, absolutely same what it was at first month. And this is the clinical video. You can see after 2 months, the patient was walking absolutely normal without even a stick. So to summarize, FLS is a sliding angular stable implant with a controlled collapse. And it seems to be promising for power 2 and power 3. For me, even for power 1, this is a wonderful implant. You can rely on this implant for all fracture neck femurs, and this looks to be a revolution. Thanks a lot for patience hearing. If you have any questions.
Thank you, sir, for the lecture. And any questions will be taken later after Dr. Ashok's lecture.
Well.
Yeah. Sir, please stop sharing your screen.
Share screen. Share better open the current. Share screen करना पड़ेगा ना अभी तो सेट शो है कहाँ चला गया वो ये आ गया इसका मेरा ऑन करो डॉक्टर अशोक पेज अब बात ये हो वीडियो से तुमने कॉपी कर दिया था होम पेज पे Good evening, friends. My thanks to Dr. Sengar and Dr. Lamba and the Kanpur Orthopaedic Association for inviting me for this talk on the new technique for fixation of the Recenet femur by PDSF technique. The biplane double screw fixation method. Slide sugar. We all are familiar with the various techniques available for fixation of the Recenet femur. The various methods, the 2 screws, the 3 screws, the garden screws, and sometimes even the 4 screws. Then the DHS, and even somebody has tried PFN also. So, what is the need for a new technique? The outcomes after displaced fractures, this study in late 1994 said that 3 cancellous screws placed parallel gave results as bad as 20 to 42%. And various studies.
सर आपका ये स्क्रीन शेयर Hello. Yeah, we have shared a screen, but then also it is showing paused. Again, yes. Actually, now it is. Now it is getting. No problem.
Sorry for the delay, there was a technical snag.
Okay.
ये ऊपर का इसमें ये फॉरवर्ड कैसे होना फॉरवर्ड किस पे होना
फॉरवर्ड तो ये राइट
ओके ये बैक ये फॉरवर्ड हो रहा है भाई बैक नहीं हो रहा कैसे होना फॉरवर्ड हो रहा है चैनल विंडोज शेयर्ड विंडोज क्लोज क्या हो रहा है चल रहा था फॉरवर्ड हो गए स्लाइड्स बैक नहीं हो रहा
बैक लेना था बस वो सर में कर
ये जो
नीचे पे बताइए 70% ये ठीक है यहाँ से
पीछे एक और पीछे यहाँ से फॉरवर्ड चलना है फॉरवर्ड Okay. So the need for the new technique arose from the poor results we were getting regularly with the three parallel screws method, and a study conducted to find out the cause of the failure rates being so high. The static analysis showed that the thin cortex of the greater trochanter, where the three screws were usually placed, was not stable enough to provide a stability to the construct so that it could act as a beam. And the soft cancellous bone placed below the beam, below the screws, was also not enough to give as strong a support as a cortical support could. So with these conventional methods, the beam formed by the screws was something like lying on an elastic foundation, and that was the cause of concern and the lack of stability. So, considering biomechanically, the high failure rate was therefore because of lack of stability, and in सब कुछ BDSF के साथ ही होना है। Right, sir. We are back. So, and inability to move the entry point of the screws distally to the solid diaphyseal cortex. So, if you look at the neck of the femur, you can place 3 screws parallel only if you are going through the greater trochanter. If you try to go below, the view that you get in a cross section of the neck starts decreasing as you go beyond. उसको कह दो यार जनरेटर अगर चलाए तो चलना रहे 15 मिनट इसको क्लोज करना. So the anatomy of the neck femur is such that it does not allow more than 2 screws if you go beyond the greater trochanter into the cortical bone. So that laid the basis of the research of Orlin Filipov, who came out with this new approach. Now, if we go with 2 screw fixation from cortical method, they are not sufficient to control the 3-dimensional fixation. Therefore, Orlin Filipov researched on this aspect and came out with an original concept of the establishment of 2 supporting points for the implants. And by placing them in a biplane positioning in the femoral neck, he was able to place 3 screws in the neck and also obtained cortical hold for 2 screws. And the increased obtuse angle at which they were positioned allow the body weight to be transferred directly in the line of weight bearing. Both these problems were resolved by the BDSF method through the concept of biplane positioning. These are 2 steady supporting points at the cortex and at the calca in the neck. The position of the screws allows them to slide under stress at a minimal risk of displacement. Now, at point A and B, we are able to get two supports, strong supports to this beam screw, which gives a lot of stability, and it acts like a simple beam with an overhanging edge. So it has two very stable points. Any beam in any construction has to have two supports. Without these two supports, any beam cannot function well. Whether it is having an overhanging or it ends on those two supports, but it always requires two supports. And this factor is the basis of this BDSF configuration. If you are trying to do this without getting the support of these 2 points, your construct will not be successful. So always we have to keep this in mind. The advantages of this method over the 3-point fixation are that the increase in the distance between the two supporting points, it gives the weight bond is over 1 unit of bone is very much reduced because the base is widespread. This also ensures that when weight bearing is there, the tensile forces are spread and the risk of its fracturing decreases significantly. An advantage of the BDSF is also that the screw placed at the higher increased angle works in direction close to the direction of the loading forces, and therefore it decreases the sagging. Now, what is important is the placement of the implants. In AP view, you will see that there are 2 parallel screws and 1 oblique screw crossing the parallel screws in a configuration of F. So it is also known as the F technique because of the configuration. But on lateral view, because of the configuration being in a biplane, you will see a V formation. 2 screws, parallel screws, they are going from posterior lateral aspect to the anterior lateral quadrants of the head, and the 1 oblique screw is going from the anterior lateral aspect to the posterior superior quadrant of the head. This way, the load is shared, and the middle and the lower screws, they are resting on the calcar and they are in the cortical bone as well. So the indications, all undisplaced fractures, you can attempt this method. In displaced fractures below 65 years, you can try this. Relatively, in patients who are above 65 years also, you can try this. And if they are unfit for THR, of course. And in bedridden low demand patients, this is relative indications. Contraindications, a small head in more than 65 years of patient, fixation failure fractures, late presenting fractures, and pathological fractures. Screw fixation is also relatively contraindicated if there is inferior combination in Bowles type 3. So one has to be careful in selecting these patients. Now coming to the technique, we are using 6.5 mm self-wrapping cannulated screws. After obtaining a reduction and preferably in slight valgus, one should start with the lateral approach, starting from just below the at the level of the end of the greater canter, laterally on the shaft, about 3 inches incision, and one has to drill 3 holes. You can start with the first hole starting at the base of the greater canter, where the cortical bone starts. Then 1.5 centimeters below that, parallel to it, and the third hole will go another 1 inch to 25 to 30 millimeter beyond on the anterior lateral edge of the window that you have made. So these the wire direction is the lower ones are going anteriorly, and the third one, the distal one, is going posteriorly, superiorly. Now you have to be careful because of the high obtuse angle of the beam screw. The distal hole is to be drilled oval. You have to create an oval hole by, you can just deviate the drill while drilling and create an oval hole, or you can increase it by with a reamer or something. Then you have to, when you are placing the guide wires have to be placed in reverse order. You have to first place the oblique guide wire, because if you place these two wires beforehand, you will not find enough space to guide this third wire obliquely. So you first place the distalmost wire and you have to rest it on the calcar and direct it to the posterior superior quadrant of the head. To get a good direction, you can use a cannulated guide to get the correct trajectory. Because once it enters such a big hole, it is very difficult to guide the wire. It usually strikes the opposite cortex and becomes dead. Then the wires are placed distal proximal. You have to use a tap to widen the hole. The screw fixation is from proximal to distal. It is the reverse. You first have to fix these two parallel screws. The proximal most goes into the anterior superior quadrant, and the second one goes into the anterior inferior quadrant of the head. You compress them, impact the screws, retighten them, and then you start fixing with the distal one. You use a tap to create the proper entry. Before placing the middle and distal screws, as I said, we have to widen the entrance so that any stress at the cortex is avoided. Like you can use even a countersink to widen it. And before fixing the third distal beam screw, you have to release the foot traction and confirm your impaction and tightening. Now, a few tips about the distal screw. You have to tighten the beam screw very carefully, because this is the one which has the danger of creating a stress riser. Stop as soon as the head of the screw touches the cortex. If you go ahead, you can create a crack in the lateral cortex. So you have to just stop short of the head touching the cortex. So when you take the length of the cortex, the length of the screw for the beam screw, add 10 millimeter to it. You will be safe. Do not over tighten the screw. Now, comparing the configuration, in the first slide, you can see that there's a gap between the lower screws and the calcar. So the elastic beam is there, and the three screws are in the thin graded truncatum. While in this, the proximal most screw is also in the starting of the cortical bone, and the other two are definitely resting on the calcar as well as the cortical bone. There's a F formation in the AP view and a B formation confirming the biplane fixation in the lateral view. Now, in 2017, it was 2011 and 13 that Filipov introduced this to the world. And in 2017, he presented a follow-up of 207 patients and a long follow-up of about 2.5 years with an awesome, I should say, a union rate of 96.6% with a very low rate of AVN also. Very encouraging results, and it definitely ensures a reliable fixation, early rehabilitation, and excellent long-term outcomes. In 2019, he has again presented this in the Journal of American Academy of Orthopaedic Surgeons, a review of another 300 cases, very successful. Now, a very common question in the last several years that I have been presenting this technique was the incidence of or the risk of the fracture by the third screw, the beam screw being so obliquely placed in the shaft. The reasoning was that below lesser trochanter, the screw can create a stress riser. But a biomechanical study was conducted on cadavers, and it was found that there was no statistical difference in the cycles to failure between the groups with the hole drilled at or below the lesser trochanter. So the results of this study indicate that placing holes below the level of the lesser trochanter in and of itself may not pose any additional risk of failure of any fracture or so. More so, as I earlier pointed out, that the placement of these screws over a wide base area itself decreases the risk of stress. Now, a few pearls from this technique. It provides early full bed bearing, increases bone union rate. It's a very strong construct, a better cortical support, increased varus resistance. There are two calcar buttressed screws and an increased torsion stability because of the biplane fixation. The pitfalls, the technique has a learning curve which requires patience. There's a great importance of perfection in the location of screw entry, placing the implant angle to diaphyseal axis, a biplane orientation of the implants, a cortical support for screws at the calcar, and very importantly, your inventory, which usually the connected screws are available from companies till 110 or maximum 115. But here you will require another 25 millimeter length. That means a minimum of 135 millimeter screws you should have. For me, I know that once I have had to use 135 also, but it's usually 125 that we use. That's usually required in Indian patients. A few examples. In this case, I'll go through them fast because another case, very good fixation, very good results. Till date, I have done about 65 cases, and out of these 65, in the last 5 years that I've been using this technique, just one case of AVN has reported till now. Just 5 days back, the union was complete, but AVN, and because of COVID, she reported late with damage to the escapulum too, and I had to do a TSR. And just one case of non-union till now. So I'm very, definitely very happy with the results. Even in a 95-year morbid patient who was not very much ambulatory, I did this with, and the attendants were very thankful for the. So when PFN was introduced in early first decade of this century, I always said that start doing it, you will love. And the same I now say for the BDSF technique. I am repeating this today. Start doing it. You will love it. Thank you very much. Any questions?
Any questions from the audience for Dr. Ashok? If there are no questions, then due to paucity of okay.
Where does the compression physical go, sir?
See, the parallel screws that you place, the first and the second screw, they are the compression screws. Once you compress them, completely impact and compress them, only then you are placing the beam screw. The beam screw is in the line of the weight bearing, it rests on the calcar, and it prevents collapse. It prevents the varus collapse. And it is in the second plane, so it provides a divergent stability to the construct.
Next.
So the hip session is now over, and I request the chairpersons for the next session on knee and leg. Dr. Sanjay Rastogi sir, Dr. Raghavan Jaiswal, Dr. R.K. Gupta to kindly come on the dais. And I will invite our speaker, Dr. Jignesh Pandya from Surat, to speak on his topic on tibial cantilever fractures. Dr. Jignesh Pandya sir, please you can share your screens.
Hello. Good evening, sir. Hello. Good evening.
Good evening. You are audible.
Yeah, I'm audible.
Yeah, you are audible.
Okay, sir. Then we are already late, so I will not waste much time and I will start. My topic is newer understanding with X-ray and CT scan of tibial condylar fractures and the approaches to access inaccessible fractures or areas. And at the end of the lecture, I think most of the people will love it to understand the fracture the way I described, and they will really appreciate the approaches which they can lead to the perfect fixation of the fractures. There are three major development in field of orthopedics. One is technology. You got newer implants, instruments, locking plates, mini fragment implants, and anesthesia. Regional blocks. We can operate high resolution for long hours.
Excuse me, Dr. Jignesh. Kindly share your PowerPoint screen.
Hello. Hello.
Yeah, kindly share your PowerPoint.
Sir, I already shared it.
Sir, please stop sharing it again.
Okay, I will do again. Okay, sure. Okay, should I share again? Yeah.
Please share your screen. Yes. Now share your talk, sir. Choose your talk. Yes.
Is it there?
No. We have not
Is it there? I have shared my talk. It is on my screen.
So please click on your talk on your PowerPoint.
Sir, I have already clicked it. Okay. Is it there?
Yes, now it's visible, sir.
Okay, sir, fine.
Yeah, thank you.
Okay, thank you very much, sir. I will start again. Proximal tibial fractures are very complex fracture, and we need to understand X-ray and CT correlation, and we need to understand the approaches which can take to the inaccessible areas to fix these difficult fractures. And at the end of this lecture, you will love to understand the fracture the way we describe, and you will definitely appreciate the approaches which will take you to difficult fracture zones. There are three major developments in field of orthopedics. One is technology. We have got beautiful implants, mini fragment implants, and instruments. We have got a development in anesthesia. Regional blocks will allow us to operate high-risk patients, and we can operate for a little bit longer hours without any dangers. And imaging study is the most important. You can see the very large letters, which has made understanding tibial condylar fracture, 3D CT and 2D CT cuts very easy, and we can now almost imagine the whole fracture in front of our eyes. These are three beautiful pictures, and it will elaborate importance of lateral view and AP view in the X-ray. So now what happens? The lioness is carrying the cub and not eating the cub. This gentleman is explaining something different and not using any absurd word. So very important to have two views. So even in CT scan, don't see only 3D, study 2D also. This will give you better idea. Now, most accepted classification of tibial condyle is Sanjay classification. So AP plane classification, it is only AP plane. See the pictures. There is no coronal plane fracture described. So we were not understanding coronal fractures. So we have to understand tibial condyle fractures beyond Sanjay classification in the coronal plane. So if I say, press any key to start, then one will say, where is the any key? So that is the confusion of understanding coronal plane fracture. Now, AO classification. That is also AP plane classification. CT not included, coronal plane not included, and type A is only external fractures. So we have to understand tibial condyle fracture. This is very good article by Leo Confant in 2013. He made tibial condyle in three parts: medial condyle, lateral condyle, and posterior condyle, which has got two parts: posteromedial and posterolateral, and that described coronal shear fractures, coronal plane shear fractures of tibial condyle, posteromedial and posterolateral. And now, even Sanjay classification was revised and revisited with CT scan in Injury 2018 by Mauricio Kofri with Joseph Sanjay, and they have also come out with posteromedial and posterolateral shear fractures, and whole classification was made CT based. And this article will need about 1.5 to 2 hours to understand perfectly well. So I request everybody to go through the article and read. Now, another way, new way of thinking, medial, lateral, and posterior. So if it is a varus extension force, it is a medial condyle fracture. It is a valgus extension force, it is lateral condyle fracture. But when it is in flexion, varus or valgus force, it is posteromedial or posterolateral fracture. So this is the morphology of the fracture and injury mechanism. You ask the history to the patient, how did he get injured? And you will come to know why this condyle has got fracture. And in anteriorly, it is a hyperextension injuries. So first I will say suspicion is the best diagnostic tool. You see this picture. There is some arrow in a posterior cortex, break in a lateral view, but AP view almost normal. But CT scan see ACL avulsion, 2D CT and 3D CT, impaction of the posterior condyle, and there is a medial condyle with posterior apex. So very big fracture which needs fixation, cannot be treated in a plaster cast. Now this was addressed by posteromedial approach, fixed with this. ACL did not require any address, and mild impaction of posterior condyle was ignored, and patient got perfect functional outcome. Now these two identical looking X-rays, left image and right image, both have got something wrong with lateral condyle. So if we see here 2D CT image, and you can see anterolateral condyle is fractured and depressed. Here posterolateral condyle is fractured and depressed. So this is anterolateral condyle fracture requires anterolateral approach. This is posterolateral condyle requires posterolateral approach. So CT scan is must. Even if you want to treat this fracture conservatively, you must see the CT scan. Now again, this case, you see there is something wrong with lateral condyle. I think it is a posterolateral condyle, because if you see the CT scan, there is a split depression fracture with impaction of posterolateral condyle of tibia. And how to operate this? If somebody wants to go from anterolateral approach, he can definitely go. He has to break anterolateral cortex, open the door, elevate the condyle, put a raft plate, with 4 screws, but none of the screw will support the posterior most part of the posterior condyle. And so this will not be a good idea because it will go for secondary collapse. So if you take a direct approach, then you can see the articular surface like this in front of your eyes. You can directly elevate the articular surface, put all the screws underneath the fracture, and plate will look like this, exactly medial to the facet of the articular surface for the fibula head. You have to use a small T plate, 3.5 distal radius, and it will look like this in a X-ray. So this is how it goes. Now we will see what we have done. See this, you can see one right side upper picture, depressed articular surface in elevated, fixed with the plate, and that's functional outcome perfectly well at the 4 months, and perfect reduction and fixation. So we will go illustrative case with the clinical operative pictures. 21-year-old female with posterolateral condyle fracture with split depression. You can see the CT images. These are the images, sagittal, coronal, and axial cuts. You can see large condyle of the posterolateral surface depressed, facing posteriorly and split of posterior cortex. And anterior, there is no fracture. Now we will see 3D CT, and it is showing split depression fracture of posterior condyle of tibia. And approach will be prone position, left side thigh, right side calf, incision directly behind the fibula, and crossing the popliteal crease about 1 inch. Make cut skin and subcutaneous tissue gently. Don't incise the fascia. Don't make a deep incision in a thin patient. You will definitely cut the common peroneal nerve, which is very close than you believe. So identify the nerve underneath the fascia. Roll underneath your finger, and then dissect the fascia from distal to proximal like this. And you can easily identify and isolate the common peroneal nerve. We have to just see it and identify it. We don't have to tag it, ligate it, or take it in a bundle, and don't retract it. It is 1 kilometer away from your operative field. Now, this is the plane between the common peroneal nerve and the lateral gastrocnemius. Okay? Once you retract the lateral gastrocnemius medially, you will see soleus in the floor over the posterior surface of the fibula head, and you just erase totally soleus muscle with the knife from the fibula head, make it white, and you will go subperiostally. And if you retract it, you will directly see the fracture. Now, once you see the fracture, you can correlate with the 3D CT. This is the articular surface which is depressed, and this is the split of the cortex. Now you can see and understand where you are. Now elevate the fragment underneath the fracture, and void is created. You fill up the void with the bone substitutes or a bone graft. I use bone substitute always. And once you elevate it, put 2 subchondral K wires, which you can see through the void that they are exactly supporting the posterolateral condyle, which is elevated, and confirm your reduction under IIT. It is confirmed now. You can see the placement of the wire perfectly underneath the elevated fragment, and void is filled up. And now put a plate, and you can again confirm your fixation. This is the closure, and there's 4 months follow-up, giving perfect functional result, outcome, and painless knee joint. Very stable. So the posterior condyle is over. Now we'll go to mysterious medial condyle. I say it is a mysterious because it is a mystery to be solved always. Now you see simple looking fracture, medial condyle total with posterior apex, treated by percutaneous anterolateral to posterior screws, leg screws. What is the outcome? Very bad. So choose the right technique and then right implant. We have to understand the fracture very well. Wrong surgery. Another case. Again medial condyle, total medial condyle fracture with posterior apex. Posterior medial approach was taken, plate was taken, but none of the screw is fixing the proximal fragment, and it is inadequate fixation resulted in the poor outcome. Now another case. This is a very common scenario in bicondylar tibia fracture with posteromedial coronal fracture. Surgeon used 2 plates from 2 sides. Anteromedial plate, fixing like this. Lateral plate, fixing like this. You can never fix posteromedial condyle by any of these plates, any of number of the screws. So anteromedial plate and anterolateral plates are bad idea to be used to catch posteromedial condylar fracture. So this will definitely fail. So what should be technique? Anteromedial plate doesn't work. Lateral plate doesn't work. And leg screw principle not applicable. It will not pull the fragment. This is a shear fracture. You need to buttress it from direct posteromedial approach. So this is again a bad idea. So what should we do? Direct approach, reduce, fix buttress plate with the screws, and the plate will look like this on the bone model. And you can see illustrative case, perfectly put a buttress plate and contoured, and you can see 100% reduction. Now, this is one more case, post-terminal condyle with AC level, and you can appreciate this 3D CT, that is the images, and post-terminal approach with a T small plate, and medial plate doesn't work, posterior plate works very well here. So now another case, two cases, this is both are medial condyle fracture, but one is sagittal plane fracture, anteroposterior plane fracture, and one is coronal plane fracture in a lateral view fracture. It needs medial plate and screw at the apex, will buttress it and fix it. And this will need posterior plate, posteromedial approach and fixation like this. So we need to understand in 3D CT, this is the scenario and morphology and structure of the fracture pattern. Now you see, this is total medial condyle fracture with dual apex. Why I say dual apex? When you see 3D CT, you see two double arrows in 2D CT. One is in AP, medial apex. One is in posterior. When there is a total medial condyle, there is always the chances of having double apex. It will be a round condyle, medial apex and posterior. So this condyle will need fixation in two planes. If you don't fix in two planes, this will definitely go into varas. So only posterior plate will not work here. So what you see here in 3D CT, anteromedially, medial apex, there is a posteriorly also there is apex. So you need to reduce condyle. Take a posterior approach, put buttress plate and reduce the posterior apex, but do not fix any proximal screws. So once you get posterior perfect reduction, put intercondylar screw to get compression between intercondylar region, and then put proximal screws. I will show you IITV pictures of intra-op. See this posterior plate, and you can see the varas is there. There is the varas. Now I have connected varas with joystick and put intercondylar guide wire. Put intercondylar screw from lateral to medial, not from medial to lateral, because medial to lateral will compress the MCL and it will hamper the movement and it will irritate the patient. So always put lateral to medial screw and then fix proximal screws in the plate, and you can see perfect maintenance of the reduction in both the planes and perfect alignment. So this is the way you have to understand the medial condylar fractures. This total medial condylar fracture are having double apex. So need two plane fixation, posterior anterior as well as medial lateral. Another case for illustration, same. Similar fracture. There is some comminution in the cortices, but similar all medial apex, medial comminution, posteromedial apex. And again it needs reduction of the posteromedial apex first, then intercondylar screw, and then rest of the screws proximally. See, similar way we have done. We have maintained the correction by joysticks, screws, and you can see outcome. Perfect flexion, perfect movement, and perfect alignment. So two plane fixation for total medial condyle with double apex. Now management changes with the time. One can understand. The upper part of left side image is an image from the Sarsgaard 1987 chapter. And there is a medial condyle fracture. Lower down is a recent image which we have got the case. Similar fracture. As the lateral condyle entered in the intercondylar region and whole medial condyle is tilted. In that book, it is medial plate and there is a posterior apex arrow. You can see it is not reduced. Here we did only posterior plate and the screw was used for the PCL fragment. So it took 30 years to move the plate from posterior to medial to posterior surface in a posterior medial condylar fractures. So that how understanding changes with the CT scan. Now this case, this is a beautiful case. Again, total medial condylar fracture. They are very likely to have impacted or depressed posterolateral condylar fractures. So again, it is a double apex, medial and posteromedial. So, and there is a large depression of posterolateral condylar fractures. This fracture will need a single approach to fix both the condyle from posteriorly and got one intercondylar screw. So let us see how we did it. Posteromedial plate, then joystick correction of the medial condyle varas, then intercondylar screw, and then elevation of the posterolateral condyle and posterolateral plate from the same extended posteromedial approach. I will show the approach. And that is the outcome at 1 year. Full function, full movement, and perfect joint. Now, this is again posterior bicondylar tibia. This is both condyle coronal plane fracture. So, we will understand this 3D CT and 2D CT images. See, A is ACL, P is PCL. PCL is a part of the posteromedial condyle coronal plane fracture, and there is a depression of the posterolateral condyle and ACL avulsion. Okay, so large fragment of ACL avulsion was there. So we have to plan how will I do it. So you see three images: posterior image, medial image, I mean coronal plane image and cross section. First, open posteromedial approach, reduce posteromedial condyle like this, put a plate, first screw at apex, don't fix proximal screws, then rest of the screws. Now elevate posterior condyle, put one more plate and fix the screw in a buttress board, and ACL was fixed. Now we will see the approach. Posteromedial incision in prone position with tourniquet, left side thigh, right side calf. Just curve the incision medially at the crease to get an access for a lateral side. Cut skin and subcutaneous tissue. Popliteal muscle is identified in the floor. Gastrocnemius is detected. And this popliteal muscle, once it is lifted, you can expose the fracture posteromedial condyle. See the picture? And tenotomy of the gastrocnemius muscle is very much important to reach to lateral side. So you don't cut the muscle fibers, just do tenotomy and it will detect far away. Okay? So total posteromedial condyle is exposed. And now you can see popliteal vessels lying between the popliteus and the middle of gastrocnemius. So they are safe. My spikes are on the lateral border of the tibia, and medial half of posterolateral condyle is also exposed. Now I will fix posteromedial condyle first. So that will pull the shaft posteriorly and I can easily access now posterolateral condyle. So this is the window for reduction of medial half of posterolateral condyle. You can see that window, cortical window. I'll elevate the window, sorry. And you can see white articular surface which is depressed, which is seen clearly in front of my eyes, of posterolateral condyle, elevated and fixed with the another T plate or a 1/3 plate or a Recon plate. And thus is the tourniquet always released before closure, and you can see the popliteal vessel lying safely over the popliteal muscle and not damaged. So I will compare with tourniquet and without tourniquet. The image remains the same. There is no bleeding. If there is a bleeding from the deeper area, it is a popliteal artery which is punctured. So be careful. There are no bleeders in deep plane of this approach. So this is the closer and then the post-op X-ray. So now this is the last part of the lecture. This is lateral condyle fracture fixation was done. You can see in lateral view, the wrap plate was put quite posteriorly. And there is some malreduction in the condyle. So this is pre-op and post-op X-ray. Is it acceptable or needs improvement? So let us see the 3D images of this picture. This is 2D and CT cuts. It was a lateral condyle, anterolateral and posterior condyle fracture. So both the condyles are fractured simultaneously. So this was done. So wrap plate cannot fix posterolateral condyle. It was left. That's why there are double shadow and double line of the articular surface. So this could not be reduced and fixed with that plate. So what should we do? First fix this fragment by posterolateral approach. Then fix up this fragment. Reduce anterolateral fragment over the posterolateral fragment and get perfect alignment and reduction. We will see the approach and the case. Now this is the case. Simple looking case in the X-ray. That somebody will say this is lateral condyle fracture and I will just do wrap plating. Okay, let us see the CT scan. This is anterolateral condyle fracture split and there is a posterolateral condyle split depression. So now you see 3D CT, 2D CT combination with the arrows. And you can identify the depressed area of the articular surface posteriorly with the split fracture of the posterior cortex. And there is a lateral condyle with the split. So it needs an approach which allows access to both the part of the condyle anteriorly and posteriorly simultaneously. And that is very important. What is that trick? It is a posterolateral approach from the Frosch without fibulostomy for treatment of tibial bed fractures. So straight direct lateral approach allows simultaneous exposure of both the condyles together, and one can reduce both the condyles simultaneously and fix it simultaneously. Now this is the lateral position, left side thigh, right side calf, and I have drawn everything. Fibula head is drawn, tibial tuberosity drawn, patella drawn, femoral condyle drawn, and tibia upper end drawn. So it is a joint line. Incision just in front of the fibula head, straight incision, right? Cut skin and subcutaneous tissue, but do not incise the fascia. We have to make two windows in the fascia, anterolateral and posterolateral, to get access to both the part of the tibial condyle. Now first we'll decide posterolateral approach. So identify the common plane now under the fascia. You can see the artery. Now dissect from distal to proximal the fascia, and now is isolated. You can see in a deeper plane. V is vessel. It is anterior tibial artery. So you are going to get a triangular window, artery now and the fracture. So that's anterior tibial artery identified. And now you can see 3D CT correlation with the picture. one arrow is showing posterior cortex of the lateral condyle. One arrow is showing the pre-articular surface, that is white. One arrow is showing anterior artery. Fibula, it is written on the name, and common peroneal nerve. So you are exactly access to the fracture area from posterior surface. So I will open that posterior window and elevate the articular surface, put one K wire from the lateral side, maintain it elevated, and then close the window. So I elevated, this is elevation, these are K wires, fixing the elevation, and this is the plate. You can see posterior lateral condyle is reduced very well and fixed with the plate, buttress plate and a screw. Once you fix this, complete the procedure. Okay, and now you can see vessel, fibula head, and now. And plate is there exactly in the position with all the screws in position. Now I will go anterolaterally, regular approach, and if required, I may do anterolateral submeniscal arthrotomy, or you can reduce accordingly through the fracture site and put a wrap plate. So this is the reduction and fixation of the IIT picture, and there is the post-op X-ray. Techniques follow perfect reduction of the lateral condyle with two plates, posterolateral and anterolateral, and perfect alignment and stability. And patient is got at 10 weeks full range of movement because of the stability. So this is how we can access the condyle anterior and posterior. So these are the approaches of lateral tibial condyle. Medial side, medial or anteromedial, posteromedial, posteriorly, extended posteromedial, lateral side, anterolateral, frost or suprafibular approach, and posteriorly, posterolateral approach. So what is new and latest? It is same, but all our understanding and knowledge which improves. So we understand in a better way X-ray, 3D CT correlation, 2D CT correlation, and we have got better implants. So that is latest and new. I cannot teach anybody anything. I can only make them think. Thank you very much. So kind of you for giving me opportunity and chance to present my work.
Thank you, Dr. Jignesh, for a wonderful enlightening lecture. And if there are any questions, we may take them now. Okay. So we will, due to paucity of time, we will jump to the next topic.
Okay.
By Dr. K.D. Tripathi. Nailing in lower and tibial fracture. What's new?
Thank you, Kanpur Orthopaedic Association, particularly Professor Sengar and Dr. Lamba. My topic is the interlocking nails in the distal tibia fractures. Usually, this fracture is a great challenge, not only because of the bony configuration, but the very delicate and very minimal soft tissue envelope in the distal tibia. It can be managed either through the conservative mode, Elizaro, X6, or plating of the both bones, tibia and fibula, or single bone plating, or nailing of the both bones, or single nailing, or hybrid fixations. Since there is a lot of soft tissue damage, soft tissue envelope is incited, so I think sometimes we need the spanning fixator, or even if there is a confusion, we can go directly with the NIPO technique or with the interlocking nail, that is internal fixation. If you are planning internal fixation, whether we should go for the intermedullary nail or for the distal tibial plates, medial or lateral, that is again the debatable subject. These fractures are quite common. Up to 8% of all tibial short fractures, the distal tibia involvement is there. It is usually the high velocity injury, but sometimes the tibial fall in the elderly osteoporotic patients, we have these kind of fractures. But in the high velocity injury, we have a lot of soft tissue damage, and along with that, we have the fracture of fibula. And these fractures usually malunite in the residual virus, valgus or recurvatum, and difficult. Distal fragment is so small that it is difficult to reduce, and distal locking is quite difficult in these small fragments. This distal fragment is 43. Particularly, I am talking of the A1, A2, and A3, that is the extra-articular, not the infract. So P and C are in the exclusion criteria. The options as we discussed: conservative, plating, intermediate nailing, external fixation like Elizaro or hybrid external fixation with the minimal internal fixation. Why the inflammatory nail? Because it is a minimally invasive. It has better biomechanics of bony configuration, gives better construct with the superior biology. We don't disturb the soft tissue at all, and this is particularly the load sharing implant and the symmetric fixation with the multiple locking options in the distal fragment. On the contrary, the newer plates, periarticular plates like distal medial tibia locking plates or lateral tibia locking plates, the anatomical metaphysical plates are available, and that we can use with the depot technique out there. The problem with the plates are that increased risk of infection with the soft tissue problems, especially in the high energy fractures. There is a, because we don't have the much soft tissue coverage, and the higher rate of hardware failure and inflammatory nail, and the delayed weight bearing, because these extramedullary implants are the load bearing implants. On the other side, the problem with the nailing is it has very distal fixation. There is mal-alignment and mal-rotation. Working length is very small, and there is no bony contact from the distal in the distal fragment with the nail. And nail length is always, we need an accurate nail length up to the articular margin, and there is a lot of difficulty in the reduction and retaining that reduction. You can see that if we are having the poor holding and poor anatomical reduction, see the outcome, it usually fails. And if we don't, they are malaligned and not reduced properly, the nailing is also a disaster here. These patients, usually 30% of them have the ipsilateral fibula fracture, foot and ankle injuries, syndesmotic injuries, and ligamentous injuries. So we have to address all these simultaneously for the better outcome. In the distal fragment with these expert tibial nail up to 37 millimeter, we have 5 locking options. So at least we can get in the very distal fracture 2 or 3 locking options always are there with the very extreme fractures. But the reduction is quite difficult. We need a lot of reduction tool. We can put the manual traction. We can use bone clips, Schenck screws, polar screws, or if at all reduction is not retained, we can go ahead with the open reduction. And we must reduce before removing, reduce and retain before removing, either with the help of distractor, or either you nail or bleed the fibula and then hold it with the joystick or calculate traction. Distractors are always in the calcaneum and the proximal tibia, and then you need to play with the first you fix the fibula, and then final moments you can play with the joystick, either with the Steelman pin or thick wire. Then you can go ahead with the guide wire must be central. If it is eccentric, then again you get the reduction, mal rotation, and magnetism. For the polar screws, I think on the concavity, if it is not very well reduced, you have to put the polar screws on the concave side and then get the symmetric alignment in the intermediate nail. And the tool of reduction is, I think, in the spiral fractures. The tall clips, these long bony clips are excellent, and then put the central guide wire and then put the central nail and then fix it with the freehand distal locking. Fibula, whether to fix or leave it, I think if there is a lot of comminution in the distal tibia, you first fix the fibula and get the length, and if it is not comminuted, then the option is open whether to fix or leave it. What exactly the literature says, the interlocking nails in the distal tibia fracture, a lot of recent papers are coming, and in conclusion, they say the intramedullary nailing of distal tibial fracture is a reliable method of fixation, possessing advantages of close reduction, and symmetric fracture stabilization. They are comparing with the intramedullary nail with the plate osteosynthesis, and there is, as regards the fibula fixation, there is no evidence in the favor of fibula fixation, but there are many papers which say that if you don't fix fibula, you can get the malalignment and the deviation of the tibial fractures. So there is, I think, papers on both the sides, but if you have good fixation of the tibia, you can leave the fibula. There are few cases, the distal fractures fixed with the fibula and then interlocking nail. These are all very distal fibula fractures managed with the interlocking nail with or without fibula fixation. So to conclude that intramedullary nailing is a very reliable method treatment of choice. Proper patient selection should be there. There should be adjuvant fixation of fibula is not mandatory. At least 2 or 3 distal screws are either stable, provide a stable contact and construct, and ultimately gives a very better outcome than the other modalities of the. Thank you. Thanks for your question.
Now we will proceed for the next session, which is the last session for the day on ankle and foot. And for this, I will invite Dr. V.S. Sharma, Dr. Nirmal Saxena, and Dr. B.S. Saluja for chairperson for session. And I invite Dr. Ajeet sir to kindly speak on fracture calcaneum.
Center stage. उसमें पेन ड्राइव में लोड करके दिया नहीं ये नहीं है कानपुर के नाम पे if you want you can take another question इसी तरीके से वो डॉक्टर अजीत को दिया था वो पहले मनिंदर का नहीं पहले आपका करा सर यहाँ होल्डर ही नहीं लगा पहले फर्स्ट योर्स बट आई डोंट सी होल्डर है मतलब हैंड सर्जन एवर को दिया था कितने है अगर देयर इज नो होल्डर है मनिंदर को कैसे मनिंदर को ये कैसे कवर करोगे कि भैया जल्दी खत्म करना है इसमें यार कुछ शादी वाले का लगा हुआ है हम इसीलिए तो कैंसिल कर रहे हैं आपका कहाँ गया मैंने इनको पेन ड्राइव में दिया था वो डॉक्टर अजीत तिवारी को मेरे ख्याल पहले आप मनिंदर का करवा अजीत तिवारी को फोन करो पहले आप डॉक्टर मनिंदर का पहले करा लीजिए
Sir, we have some disturbance, some problem, and I request Dr. Maninder Singh Shah to kindly share his screen and resume his talk on Lisfranc injury in knee light.
टाइम के लिए भी बता दो टाइम के लिए 10 मिनट में टाइम के लिए बता दो
Dr. Maninder.
Yes, just give me half a second. I'm just gonna start. Thank you so much.
Yeah. And please stick to time limit. As we are already late.
Sure.
Yeah.
Okay, can you see my screen?
Yes, sir.
Okay, great. And can you hear me properly? That's okay. My voice is audible.
Yes.
Okay, right. Okay, thanks. So I would like to thank UP Orthopaedic Association and Dr. Sengar and particularly Dr. Lamba for the very kind invitation. So I've been given the topic to speak on Lisfranc injury, where we stand today. And I would go on straight away to a X-ray. And if you see this X-ray with a 30-year-old twisting injury of the foot, you can see there's nothing much wrong in this except for a small step here, which you can see. And this is why the lateral view is really, really important to get in a foot injury, because you can see the small steps and you may not see any displacement on the AP and oblique views. And even this step is very, very significant. Just going on to the 3 columns, because these are really important. The medial column, which is just the first ray, has a movement of 3.5 millimeter dorsoplantar movement. The middle column, which is the most stable column, has only 0.6 mm sagittal plane movement. That is important because we need to, think about how we restore these columns back. And if they have abnormal movement because of the injury, because of the ligamentous injury or the bony injury, then these are not stable enough to withstand the body weight, and they can collapse and cause a midfoot collapse following a Lisfranc injury. And the lateral one is the most mobile, and it's got a 13 millimeter sagittal plane movement, and that's why we don't fuse these joints, the 4th and 5th. We only reduce them. Okay, so that's the concept regarding the ligamentous, the Lisfranc stability. The ligamentous stability is provided by the Lisfranc ligament, which is the ligament between the base of the second, the medial cuneiform, and the base of the second metatarsal. It is because the first, second intermetatarsal ligament is lacking, and that is replaced anatomically by the Lisfranc ligament. Okay, so the classification, I'm not going to go into that. It tells us about the mechanism of injury and guides to possible treatment, but it does not tell us about what to do and what is the prognosis of the injury. So we're not going to go into the classification. We're just going to straight away go into the diagnosis. How do we diagnose a Lisfranc injury? The patient has had a significant trauma. Minor trauma is rare with a Lisfranc injury, although with osteoporotic bone, even minor trauma can cause a midfoot fractures. Now, midfoot ecchymosis, pain out of proportion to the injury will give you a suspicion. So if you see any, bruising on the plantar aspect, it is a sign of having a significant trauma to the midfoot, and you need to have a high index of suspicion, especially for ligamentous injuries which are not visible on the X-ray. So if you look at this, this is a neglected Lisfranc fracture, and the patient initially did not have any deformity. However, this is 3 months down the line, he gradually developed a midfoot collapse. As you can see here, it is a completely collapsed midfoot, and the collapse is actually at the midfoot and not at the subtalar joint. But this makes the heel go into valgus as well as a secondary change, just to get the plantigrade foot. So it's important to recognize these deformities. Now on X-rays, we know all the lines to see. We need to get all the views, AP, oblique, and lateral views to make sure we are looking at the displacements correctly. Now, the important sign to see is the fleck sign, which you can see a small fleck of bone. Just here, if you see that, just a small fleck of bone, that tells us that the Lisfranc ligament has been avulsed. Now, weight-bearing X-rays are the most important X-rays to have in a Lisfranc ligament. As soon as the patient is able to weight bear, we should get weight-bearing X-rays, especially if we're treating him conservatively, because in this study, which was published in 2020, Archives of Trauma, Orthopedics and Surgery, 24% of injuries are missed on non-weight-bearing radiographs. So it is important that if you're not getting a CT, or we must do, or if we're suspecting a ligamentous Lisfranc, it must do weight-bearing X-rays. And that gives us, if you see the stress view, you can see the weight-bearing difference between the non-weight-bearing and the weight-bearing, the stress view. So if there is opening on the weight-bearing, then you can know this is unstable fracture, definitely requires fixation. Otherwise, it will lead to midfoot collapse later on. Now, CT and MRI are the cornerstone. Now, weight-bearing CTs have come into their own. They're not available in India widely at the moment, but in the West, it is now, a standard protocol for doing a weight-bearing CT in a lot of these cases, especially where the diagnosis is not very obvious, especially like ligamentous Lisfrancs. But CT will tell you about small fragments. It will tell you about other fracture, which you may not have seen, like a cuboid fracture, which may be associated with a Lisfranc injury. And it will also tell you about, and MRI will be useful in a ligamentous Lisfranc injury. So what are the issues in a Lisp frank injury and what we need to identify? How do we treat them? So we need to ascertain whether it is a stable injury or an unstable injury. Stable injuries can sometimes be treated conservatively. Unstable will always treated operatively. And how we decide whether to conserve or operate, and what is the timing and method of fixation. So we'll go on to these issues. Now, conservative management, if you look at these two studies, this was the study in 2020, the first one in Foot and Ankle International by Chen et al. They looked at around 50 patients who were conservatively treated with and were undisplaced injuries to start off with. And they found that 54% displaced at around 18 days. So all undisplaced injuries are not stable. So you need to keep a very close look on patients which you're treating conservatively. So you need to have undisplaced and stable injuries. Only those you can treat conservatively. Any undisplaced, which are unstable injuries, you need to get a weight-bearing X-ray to look for instability. If there is instability, it is definitely better to operate. The other one, other study in 2021 in International Orthopaedics looked at basically the outcomes, clinical outcome in Lisp frank injuries, operative versus conservative management, and they found that if you were to decide properly the groups in which you do conservative versus operative, then conservative has similar outcomes as long as they are not unstable. So we need to find out whether it is an unstable injury by doing the X-ray. So conservatives only for undisplaced plus stable injuries. Both of these criteria should be met for us to treat these conservatively. Now, what are the outcomes following surgery? It depends on what two main factors affect the outcome, whether the fixation method and the anatomical reduction. Now, the fixation method can be either with screws or plates. And the single most important predictor of functional outcomes has been shown to be anatomical reduction without any doubt. So if you achieve anatomical reduction and you achieve some stability of fixation till the wound, till the bone has healed, you will get a good outcome. So getting an anatomical reduction is really, really important. And if we see this study, if you get anatomical reduction, 50 to 90% good results. If you got a poor reduction, even with surgery, you would get only 17 to 30% of good to excellent results. So it's an important criteria to restore the anatomy completely as you would. So the treatment options can be stabilization with K-wires, which is the original treatment, then articular screws, dorsal bridging plates, or a tightrope. And then the other option is a primary fusion. So these two will talk about whether primary fusion is better or stabilization with plates or screws is better. So we're just gonna see a video. This is a ligamentous Lisp frank injury, basically treated with a plate. So if you see the CT, it showed displacement on the CT, but on the X-ray it looked undisplaced. Now the standard approach for treating a Lisp frank can be two ways. Either you can go in the first web space, or you can go over the third metatarsal. If you go over the third metatarsal, sometimes you have to do a separate medial incision if you have to fuse the first TMT as well. So this is an approach over the first web space. So you have to be careful that there is a neurovascular bundle there in the first web space, and it is important that you sort of the bundle is identified. So we'll just show you how we identify that bundle. Now, this is the intercuneiform space and the base of the second metatarsal and the area of the Lisp frank ligament where the, and this is a second TMT joint where the thing is going. So identify the joints. You see that the intercuneiform is also unstable. So in this one, because this is a ligamentous Lisp frank, we opted for a fusion. So denude the second TMT joint. The first TMT was stable even on stressing. So don't need to do anything for that. You don't need to routinely fuse the first TMT in all Lisp frank injuries. You have to assess the instability, only then you need to fuse. So once we've denuded everything and you assess for that, then this is the neurovascular bundle here. So you identify that, because we're going to put a plate over the second metatarsal. You can't put a plate directly unless you've actually identified this neurovascular bundle, which is dipping into the first web space. So once you've identified the neurovascular bundle, then you can go ahead and actually put a plate underneath it. So this is the first screw, the home run screw, going from the base of the second metatarsal into the medial cuneiform. So if you see that, that's the trajectory. It is better to put it from the second metatarsal, because then you have a good area to target. if you put it from the medial cuneiform, the targeting the second metatarsal is sometimes difficult. Now you see that it is stable because of the screw, and you can just put a bridging plate across this thing, and then this is the final X-rays, and the result is what you see. So you don't need to do anything to the first TMT if it is a stable injury, and this is all you need to do. But it's fusion. So looking at another injury, this is a road traffic accident. Was a closed injury though, but it was very severe, very swollen. This was treated with K-wires at some other center, and basically the patient did not want any other surgeries. We took the K-wires out at 6 weeks. However, did not have a good result and required further surgery after that. K-wires are not recommended nowadays because the fixation is only lasts for a few, after 6 weeks or 4 weeks, you have to take the K-wires out. They get infected, they get loose, and they lose their fixation. So better to fix with screws or plates. Now, this is a lady who 30-year-old housewife tripped on the street and got this fifth fracture and was treated with a traditional method of screw fixation across the first and second TMT joints. This is a very old case. And so screw fixation is traditional gold standard, but it damages the articular surface. The anatomical reduction is the key to success. Even if you use screws, it is important to open reduce the fracture and not do a close reduction and screw fixation. That is not acceptable. Screw breakage is a problem. You have to keep the patient non-weight bearing for a much longer time than with plates. So plates is a preferred method nowadays. So if you were to do a study versus whether you want to do a ORIF versus primary arthrodesis, there is no difference in the main outcome rates with either ORIF or primary arthrodesis. But now in the last 2 or 3 years, more and more studies have come out that primary arthrodesis is better, even with all kind of Lisfranc injuries. And these studies have shown slight better outcomes with primary arthrodesis than ORIF. So the traditional thinking is even evolving now that we should be doing more of primary arthrodesis even for routine Lisfranc injuries. Again, anatomical reduction in either of those, whatever you do, anatomical reduction, restoring the anatomy is most important. Now, whether we want to use a dorsal bridge plating or screws, there have been few studies that show that the plating is better than screw fixation. You get the patient early, you don't need a plaster to be put on post-operatively, you can mobilize the patient straight away. Obviously, we keep them non-weight bearing for 2 to 3 weeks or 4 weeks, and then you can gradually partially weight bear with them with the plate on. So it is much quicker rehab. Patient gets back much better earlier. If you look at this 30-year-old, if you see this, the cuneiform is also subluxed out of position. But if you see the AP, it doesn't look very bad. But if you see the CT, there's a cuboid fracture as well. The 4th and 5th doesn't look very well aligned. So on the CT, it showed that there was a cuboid fracture. So you need to fix the cuboid fracture as well along with this injuries, and you fuse the second, third TMT. Majority of times you don't need to do anything to the first TMT because in majority of the cases it's usually intact, but you must check for the instability and fuse that as well if that is required. Now, this is a 68-year-old lady who injured herself while playing tennis. She was very active. She's actually a mother of an orthopedic surgeon. So she, on the X-ray, didn't look too bad. But if you do a CT, you can see the fracture of the cuneiform as well, and significant fractures of the first, second, third. All of them were sort of unstable. So she required plating fixation across the second and third with fixation of this. And this is her 4 months down in Sri Lanka. After the surgery, 4 months after that, she went on a beach. She did a 5-mile hike on a mountain, and she sent me those pictures as a thank you note. So this is what you can do with early quick rehab with Lisfranc injuries, which is not possible if you use K-wires or screws. So this is a 35-year-old airport worker, just an example of showing a more severe injury where the cuneiform is already subluxed out of place. And you can see the medial cuneiform is also fractured here. In this, the first ray needs to be realigned back, and you need a better bridging fixation involving till the navicular. And you may need to fuse these intermediate joints. It's usually better to fuse these severe injuries because they do better with fusion rather than just with bridge plating. Now, so coming to the last slides, really, ligamentous Lisfranc, primary arthrodesis definitely has better results. In bony Lisfranc, the jury is still out, but more and more evidence is coming towards primary arthrodesis in Lisfranc injuries. Accurate reduction and fixation is the key to getting good outcomes. Locking plates have been shown to be better than screws. primary arthrodesis may be better than or a standard bridge plating. So take home message, it is a complex fracture. We must do weight bearing x-rays. We must scan, do a CT or MRI depending on the bony or ligamentous nature. We can do conservative for certain undisplaced but stable injuries. We should respect the soft tissue envelope, always operate after a week or 10 days after the swelling has gone down. Anatomical reduction is the key. Maintain the column length, and stable fixation will give you very good results for your patients. Thank you very much.
I know I'm the last speaker, and it is hard for you to hear me, and it is equally hard for me to deliver this talk. And there is time constraint from the organizers, so I'm trying to convert this lecture into a message. So it's I will just try to quickly wrap up the things, whatever I have to say. So, slide show. Okay, my first talk is on calcaneus fractures, and this was what was initially what we used to think about the calcaneus fractures, and now we have solved these problems, and you see we have seen quite improved outcomes of the operative treatment of the calcaneus fractures. Why this has happened, we need to understand. The most important thing is we have realized it is not only the subtalar joint which is important, it is the shape and the anatomy of the calcaneus which is important, and we need to restore the shape, the height, the length, as well as the pitch, the direct pitch, which is more important. So fortunately, I think this slide is video is not playing, so we'll save the time. And so with this video, I just we wanted to show that how the Sanders classification help us to decide. So the latest thing which has happened is we have studied where the fragments are and where these fragments are going and how we pick it back. So we are improving day by day in our imaging modalities to know what are the different fragments. That is one message which I have to say. Then we have learned what are the approaches available and what are the pros and cons of these approaches. Okay, there was time when we had quite a lot of complications with the extensile approach, but now we see that we can improve on our extensile approach if we keep our incision, just anterior to the tendoacetus, which I see, and this green area which is there. I don't have a marker where you just see the flap, and we have discussed this in one of the chapters of the book of Essential of Foot and Ankle Surgery. So the other thing which I have seen is that in patients where the lateral calcaneal artery is patent, and if you see on ultrasound that it is patent, then you can have a very less chance of getting a flap necrosis. So these two things, messages I want to convey: keep your incision just anterior to the tendoacetus, sharp dissection at the curve, and if you can have the facility, just see the lateral. So this is, bilateral calcaneus. We have come through lateral extensile approach, and this. Then we know the patients where we should avoid this approach. So that is very important. So these are just, I'm not going to go into details because of the time, but you should know where you don't have to use this approach. That is another message I want to give. Sinus torsii approach has got definitely less wound complications, but it is applicable only to the Sanders 2 and AB. So this is the algorithm where, again, if you look, this part, it is just applicable to the Sanders 2 AB, and as your experience grow, only then you venture on the sinus torsii. This is again a bilateral fracture where we have done a sinus torsii, and it is a technically demanding procedure before you go there. And now there is a paper which shows your incision for the sinus torsii has to be modified, which has to be straight from the distal tip to the fibular tip, so that it increases the chances of the sural nerve injury. Then coming to percutaneous fixation. What we can do percutaneous fixations, and whatever you do, you must understand you have to reduce the fragments. To reduce the fragments, we must learn how the things can be used. Just see, this is a tongue sort of fracture, and we just did in a percutaneous way, handled it with sham spin, reduced it, and just fix it with the screws. Another bilateral fracture. Again, a percutaneous approach. We again use sham screws. Then two screws were used, and then another screw from the tuberosity to the anterior and cutaneous, and we manage it. The other side, we just passed a transcalcaneal pin to bring the varus tuberosity to varus. Once it was brought there, then we fixed it with the screws, and then again. So it was just percutaneous incisions that we could manage this, so we should know how we can reduce the tuberosity. These are the different methods. Short of time, cannot elaborate, but you should know you can use your shank spin, you can use your K-wires, you can use your distractors, and then you can use how this is here. We have just lifted the depressed intra-articular fracture with the periosteal elevator and stabilized it with a K-wire, and then fix it with the screw and the blade to the sinus side road. You can use even the fixators to get the tuberosity out, and this is how you can use the fixators. So sometimes you can go on the medial side and put an extra plate to get the medial tuberosity into position. And then if you cannot reconstruct, you can do arthrodesis in these patients. And it is, you can get a good results even with a primary arthrodesis. And this is one of our cases where we did the primary arthrodesis. The other message is, when you are doing the primary arthrodesis, you have to again maintain the anatomy of the calcaneus, and that is very important. Only then it is going to work. So in the end, can we put the Humpty Dumpty back? Definitely. But I caution the last words. The poorest treatment results are reported after open surgical treatment that failed to achieve anatomic reconstruction of the calcaneus and joints, thus combining the disadvantages of both operative and non-operative. So please learn these techniques and then go ahead to into the surgery. So thank you very much. Now I move on to very small next talk, which is on the. So I'm not elaborating on the things. So I'm just giving the message to wrap up the things. I know all of you are fed up. I can understand that it is. And I think the high tea is a savior for me. Some people are there, so they want to have a high tea. So that high tea has probably saved a few people who are there. So quickly, I will run through. No videos. I'm not going to show any videos because they are going to take again just short messages. What I want to give through my talk. I don't know if it's not there. Slideshow, please. Yeah. So, okay, now I move on to the posterior malleolus. This can happen, as a part of a trimalleolar fracture. Then there is an axial variant, and sometimes you can have this is very important, the last part. You see, 1,013 fractures, were low torsional fractures, tibial fractures. And see, 9% rate of, so don't miss this. That is all I want to say. These are the red flags where you see the torsional tibial fractures, you can have a posterior malleolus fractures. Now, my talk is basically why to fix it, how I assess it, and then how I approach it. So, why to fix it? Because PITFL is that and it gives the syndesmotic stability. That is why we fix it. But if you have fixed it, don't get carried away that everything is solved. You may even have to fix the syndesmosis again. Number one message, after fixing the posterior malleolus, please check the syndesmosis. And you see in this case, even after fixing the syndesmosis, the ankle was not stable. So we went on the medial side and the deltoid repair also. So fixing the posterior malleolus is not a guarantee to the stability. Keep on checking the stability. That is the message I want to give. Then Why to fix it? If you see, there is a decrease in the contact surface when there is a fracture. If you see it, the contact surface is decreased, so you are likely to get more osteoarthritis. Other thing is, if you don't reduce it, your talus will remain posterior subluxation. So you need to put the posterior malleolus back. Now, and the other is your fibular notch is disturbed if there is a posterior malleolus. So you see, there are many reasons why we want to fix the posterior malleolus. And on this basis, classification has been suggested whether it is involving the fibular notch or not. Then, what we want to do, we want to assess. And in assessment, we must understand the fracture anatomy, how far medial it is gone, whether the fibular notch is involved or not, or what is the size of the fracture. And you have to have, you see here, the picture above never showed the size of the, look how big the posterior malleolus is. There are certain signs, a double medial contour sign, then you can see the fraction, and then you can see there is a vertical slit on this. So these are the warning signs on the X-rays which you should try to pick up. And then it has been shown if you have a taller height of the fracture, then it is likely to have a more medial extension. These use help something, but these are out of the gold standard is the the CT scan in this, because then you can classify the fracture, what type of fracture it is, and you see with type of the fractures, the injuries you expect. With every fracture type, whether you are likely to have a syndesmotic injury or a medial injury, this has been predicted in the literature. So once you know the fracture anatomy, now you look for those injuries also, and you need to address those injuries. And this is one of the latest in 2020, how you can divide these fractures, and then you plan your approach to these. So whatever the fracture types are, you have the approaches. You can use all these posterolateral, medial or modified approaches. And then this is what is the kind of the exposure which you are going to get to these approaches. And we have described again these approaches in our one of the books, which is essentially the foot and ankle surgery. These approaches are available who wants to go through it. Now, how to fix, whether anterior to posterior or posterior to anterior, screw or plate, on which malleolus first or this. So it has been proven that the superior to posterior to anterior fixation is good, and I use anterior to posterior only in the rotational fractures, which I mentioned. This is a distal tibial fracture where we have used anterior to posterior. Otherwise, it is a posterior to anterior fixation because of the better biomechanics. And as far as to use plate or the screw, you can use both depending upon the size and the fracture anatomy. Here you can see what first. If you have a low fibular fracture, then do your posterior malleolus first. If you have a high fibular fracture, then you can fix the fibula first and then do the posterior malleolus. So in this case, we chose the, I don't know, these videos are not going to work, posterolateral approach. And we had the fibula first so that the posterior malleolus falls back. So once the fibula is done, the posterior malleolus falls back. We fix the posterior malleolus first, if you see on the top right, and then we fix the fibula. So this was the sequence in this case, and this is what we got. Another case where it was extending more into the medial side, if you see the anatomy. So we used a posteromedial approach, and this is how we went, and we did it through the posteromedial approach. I don't know, these are videos are not good. So now stop moving. Again, I'm just about to finish. Yeah, again, I don't know whether you can get it or not. I can just conclude it like this only. So the first thing is that you need to understand the anatomy of the posterior malleolus, see the posterior malleolus, and then you see from which side you have to approach, from the posterolateral side or the posterolateral side. You can use, I had cases where I used the two plates, where one is for the posteromedial fragment and on the posterolateral fragment. So that was the last I had there, where the two fragments were addressed differently to the posteromedial and the posterolateral. I don't know if he is able to do it. So that is in the end, I would just like to conclude that study the fracture pattern on the CT, axial CT scan, and then decide the approach. And most of the time, it is posterior to anterior fixation. The screw or plate can be dependent upon what is the size of the fragment. Anterior to posterior is used when these fractures are associated with the torsional fractures of the tibia. That's all. Thank you very much.
Sorry, I'm sorry. I'm very sorry. I wrapped everything at the same time.